Welcome to yet another class organized by DNET's Academy for your NEET SS preparation. So today I'm asked to cover about the lower GI in general, the general surgical aspects, and mostly I'll be covering a broad basics and protocol of management of some of the common GI condition, and I'll be going mostly textbook based, which is most commonly, which is the substance based facts. And at whatever stage you want to have you have any doubts or any clarification, you can stop me and ask. And I'll go fast because there's very short time, and I'll try to cover as much as possible the important concepts of the lower the lower GA given in substance. Fine. So let me start. So any time you can stop me and ask if you have any doubts in any of the points which I'm telling. Fine. So I'll start straight away from the malignant part of the lower GA, the colorectal malignancy, following which I'll cover about the anatomy and the benign aspects. Okay. So since colorectal malignancy is very important, I'll start with the colorectal malignancy. So I'll brush up with the most important aspects and the most important points which you have to concentrate for cracking your MCQs in the NEET super specialty exam. The first thing in the colorectal malignancy is what you have to remember is this multi-step carcinogenesis, which happens in the colorectal carcinoma. So unlike other malignancies, the colorectal malignancy follows a sequential multi-step model in which a normal colonic epithelium progresses sequentially into early adenoma, intermediate adenoma, late adenoma, and a carcinoma. Finally, it metastasizes to other organs. So it is also called as multi-step carcinogenesis, also called as adenoma carcinoma sequence. And this was given by Fehr and Vogelstein. So this is a very important flowchart which is given in Sabiston. So make sure you look at this table every day so that it just comes to your mind whenever you see a question relating to this. So let's see this one by one. See, for example, the normal colonic epithelium, the first mutation which happens to follow this to go through this adenoma carcinoma sequence is the APC gene mutation. So the APC gene is basically a tumor suppressor gene. So the most of the genes in this flowchart, this is a tumor suppressor gene except KRAS, which is a proto-oncogene. So all others are tumor suppressor gene. So this is a oncogene, whereas all others are tumor suppressor gene. So this is a tumor suppressor gene, this is a tumor suppressor gene, and this is also tumor suppressor gene, P53. So just see this, the normal colonic epithelium, the first step is the APC mutation. And in a square bracket, I've also given what chromosome the particular the gene is present. So I have given the APC gene, in which chromosome it is present. So it's present in the 5q21. So fifth chromosome in the long arm of in the 21 sequence. Same thing, the DCC mutation is present in 18q. The P53 mutation is present in the 17p chromosome. So what happens once there is an APC mutation, there is a dysplastic aberrant crypt foci, which is the first initial step, following which the tumor goes into early adenoma, and after which when there is a KRAS proto-oncogene mutation, it becomes intermediate adenoma, and then further mutations occurs in the form of a DCC mutation, which is again a tumor suppressor gene, and it progresses to late adenoma. The final step which happens for the progression of adenoma to carcinoma is the P53 gene mutation. The P53, also called as the guardian of the genome. This is the most important tumor suppressor, the mutation of which leads to the conversion of adenoma to carcinoma. So also remember this thing, that there is a normal tissue. They have a concept of tumor initiation. Then there is a tumor progression. Finally, there happens a neoplasia. So they have described these two things in terms of the two most common hereditary colorectal cancer syndrome. One is the familial adenomatous polyposis, and the second is HNPCC, hereditary non-polyposis colorectal cancer. See what happens, the major difference you see in FAP, familial adenomatous polyposis, the tumor initiation is accelerated because of the germline APC mutation, whereas in HNPCC, the tumor initiation is normal. Okay, so that's why in FAP, the tumor initiation is abnormal, and the patient start having polyp in the second decade of life, which is not the case in hereditary non-polyposis colorectal cancer, which happens in which the malignancy starts a bit later when compared to FAP. At the same time, see this tumor progression. The tumor progression is a normal. normal in FAP, which is around 5 to 10 years. That means once the tumor initiation has happened because of the mutation in APC, the progression takes a bit longer time, about 5 to 10 years. Whereas you see the HNPCC, once the tumor initiation happens, the tumor progression is very accelerated. This is because of the mismatch repair gene mutation. So the tumor progression is very prolonged. That is 5 to 10 years in FAP, whereas 1 to 3 years in HNPCC. And almost the most important point is what is the risk of colorectal cancer in these two most common hereditary colorectal cancer syndrome. FAP, 100% risk of colorectal cancer. If you have a patient with a documented APC gene mutation and a family history of FAP, he has a 100% risk of colorectal cancer and is definitely going to benefit from prophylactic total proctocolectomy. Fine. At the same time, when you see HNPCC, it has a 70 to 80% lifetime risk of colorectal cancer. So these are the important aspects which you should remember in the table. You should remember at what point each of the gene acts. In short, you remember that APC acts in the initial point where the normal colonic epithelium gets started off with the dysplastic aberrant crypt foci, and the final point where the late adenoma to carcinoma comes the P53. Also remember, in FAP, the tumor initiation is affected because of the APC gene mutation, whereas in HNPCC, tumor initiation is normal, but the tumor progression is very rapid when compared to FAP in HNPCC. And also remember, in FAP, there is 100% risk for colorectal cancer, whereas in HNPCC, there is only 70 to 80% lifetime risk. So this is the multi-step carcinogenesis or adenoma carcinoma sequential model, or the Fehr and Vogelstein adenoma carcinoma multi-step model. Fine. The same thing which I've explained, the difference between the progression of the adenoma carcinoma sequence between the two most common hereditary colorectal cancer syndrome, one is FAP and HNPCC. And what happens, as I said before, in FAP, the tumor initiation is accelerated, whereas in HNPCC, the tumor initiation is normal. At the same time, what happens once the tumor initiation, then happens a proto-oncogene mutation, and finally the tumor progression happens. And finally, once there is a P53 gene mutation, it undergoes the adenoma becomes a carcinoma. So you see this tumor progression in FAP, tumor progression is normal, whereas in HNPCC, tumor tumor progression is accelerated. So there is a difference between tumor initiation and tumor progression between FAP and HNPCC, the point to be noted. Fine. Again, the same thing, I'm again repeating this because this has been repeatedly given in Sebastian also, as well as given in any textbook as a basic a concept of a colorectal malignancy pathogenesis. Fine. So just again see this flowchart. There is a normal epithelium, the first one. And what happens, the first mutation is always the APC gene mutation, which is a tumor suppressor gene, as I said before. Okay. Then what happens once there is a mutation in the APC, there is a dysplastic epithelium. So what happens next? It forms an early adenoma. So once there is an early adenoma, once there is a KRAS mutation, which is present in 12p chromosome, early becomes intermediate adenoma. From intermediate to late is because of another tumor suppressor gene present in 18q, which is DCC gene mutation. So from late adenoma to carcinoma, it's because of P53 mutation, which is again a tumor suppressor gene. So most of these things are tumor suppressor gene, except KRAS, which is a proto-oncogene. So proto-oncogene, all others are tumor suppressor gene. So remember these four genes starting with the APC, followed by KRAS, DCC, and finally from the late adenoma to carcinoma is the loss of function of P53 gene mutation, which is present in 17p. Fine. So this again the most common cancer genes. So there are three types of cancer genes which involved, which can be, one is proto-oncogene, second is tumor suppressor genes, third is mismatch repair genes, MMR genes. So these are the three important genes which plays an important role in the colorectal cancer pathogenesis. So the proto-oncogenes, the most important of which is this c-MYC, RAS, SRC, and ERB, out of which KRAS is the most important proto-oncogene. So whenever a proto-oncogene gets mutated, that is the gain of function mutation, it results in the conversion of an adenoma into a carcinoma. Next comes a tumor suppressor gene. So what is important tumor suppressor gene? As you've seen before, APC is important tumor suppressor gene, and then followed by P53, followed by DCC. Okay. Also remember the chromosome in which all these genes lies. Just jot it down in a paper and stick it in your wall and look at it every day so that it goes. I mean, you can remember any time in which the question is framed. Okay. And the final, the other set of gene is MMR gene. Mismatch repair genes are basically they repair the DNA in case of any mismatched base which is paired during the DNA synthesis. And that if the mismatch repair genes are mutated, so these genes are basically MSH2, MLH1, PMS1, PMS2, MSH6, and if these genes are mutated, results in HNPCC, hereditary non-polyposis colorectal cancers. There are three. So basically, there are three types of genes. One is proto-oncogene, followed by which is KRAS is the most common, followed by tumor suppressor gene, the most common of which is APC and P53. And MMR gene, we have an array of genes, which is MSH2, MLH1, PMS1, and MSH6. So let's take one by one. This has solved this MCQ. So identify the false statement regarding APC gene. A, the APC gene is a tumor suppressor gene located on chromosome 5q21. True or false? Anyone?
True.
True. Wonderful. APC helps in cell cycle control by regulating the intracytoplasmic pool of beta-catenin. True or false?
True.
Wonderful.
True.
So basically, the APC gene, it has, I mean, if you see in Shackelford, they would have given a picture about how APC interacts with the WNT signaling pathway, and thereby it regulates the amount of beta-catenin which is present inside the cell. So basically, in short, you remember that APC controls the cell cycle by regulating its activity about the amount of beta-catenin present inside the cytoplasm. Okay. The earliest phenotypic change present in APC mutation is known as aberrant crypt formation. True or false?
True.
True. Wonderful. So the earliest phenotypic changes in APC is aberrant crypt foci. Is the earliest crypt changes which happens in APC gene mutation. The most consistent genetic aberration within the cells are abnormally short proteins known as APC truncation.
This will be false.
So yeah, no. This is also true. So all the statements here given is true. So basically, APC gene mutation results in a truncated form of APC protein, and that is called as APC truncations. Fine. So APC gene mutation results in APC, that protein becomes truncated, that becomes short. That is called as APC truncation. So that is also true. So remember, earliest phenotypic change is aberrant crypt formation, and because of the APC gene mutation, it results in short proteins known as APC truncated proteins, and always APC acts by regulating the intracytoplasmic pool of beta-catenin. Okay, and as you all know, APC gene is a tumor suppressor gene. So remember, in colorectal cancer, the one most important proto-oncogene is KRAS. Apart from that, most other or tumor suppressor gene. Okay, let's do the next MCQ. Identify the false statement in regarding FAP. 30% of FAP cases are due to de novo germline mutation without a family history of the disease. True or false? Can everybody answer? If just true or false? I mean, it's okay if you're right, or I mean, if you're wrong. Yeah, someone has answered true. That's right. So remember that though FAP, familial adenomatous polyposis, is a hereditary colorectal cancer, not every patient will have a positive family history. Up to 30% of FAP cases won't have a family history of the disease, and those cases are basically due to a de novo germline mutations. So that patients, so that happens a new mutation in the germline, so they may not have a family history of a FAP. Fine. So option A is true. Option B, it is typically characterized by more than 100 adenomatous polyps present in the colon and rectum. True or false?
You're true.
True. Yeah, wonderful. True. True is good. Uh, so the basic phenotype in any FAP is the presence of more than 100 polyps. Sometimes the polyps may be present in thousands, which is diffusely scattered throughout the colon. Option C, mutation close to the 5' end of the gene produce a short truncated protein that causes the syndrome known as attenuated FAP or AFAP. True or false? If the mutation is close to the 5' end, it results in attenuated AFAP. True or false?
True.
Yeah, that is also true. So always remember, suppose this is the DNA, and DNA definitely it has a 5' end and a 3' end. So any mutation which is close to the 5' end or to the 3' end will always result in an attenuated AFP. So in the APC gene, when the mutation is close to the 5' or 3' end, the ends, it results in attenuated FAP. Fine. Option D, classic FAP is characterized by truncation mutation occurring in the gene from codon 1250 to codon 1464. There's a point which is given in substance. That's why I particularly taken this minute point from that. Which is it true or false?
True.
It's a
Yeah, yeah, this is true. So what happens is that in this codon, the codon 1250 to 1464, if mutation happens in this zone, this zone is also called as mutational cluster zone. Mutational cluster zone. Mutational cluster zone. So in this zone, if mutation happens, it results in a classic FAP and the patient will have more than 100 polyps, sometimes even thousands of polyps. Whereas if the mutation happens in either ends, either the 5' end or 3' end, it results in an attenuated AFP where the patient may not have as many polyps like in a classical FAP. So I hope these points are clear. Always remember, up to 30% of FAP cases won't have a family history of disease. Why? Because there might be a de novo germline mutation. And other points are very clear to you. Fine. You're clear with this point? Fine. Can I go ahead? Can I have some feedback?
Yes, sir.
Yeah, fine. So if any doubt you have, you can stop me and ask. Fine. Thank you. So other important thing, as I said before, in the multi-step carcinogenesis model, the starting point is the APC gene mutation. And the end point by which an adenoma converts into a carcinoma is the P53 gene mutation. I'll again show that picture. So the end point is the starting point is the APC mutation. The end point is the P53 mutation. Fine. So what is the role of this P53? As you all know, the P53 is basically the cell cycle checkpoint inhibitor. What it does is whenever there happens a mistake in the DNA synthesis, what it does is P53 causes cell cycle arrest and repairs the DNA and corrects the whatever damage has happened. But when P53 gets mutated, this repair doesn't happen and results in a mutated protein, which results in the carcinoma. So basically, the P53 mutation happens in most of the colorectal cancer, up to 75%. And as we all know, as I showed before in the flowchart, it occurs late in the adenoma carcinoma sequence. APC mutation occurs first, P53 mutation occurs late. In fact, it occurs the last in the adenoma carcinoma sequence. And how does P53 act? Whenever there is any damage, it causes apoptosis. Of the whatever the cell the damage has happened, or it can cause the G1 cell cycle arrest and repairs the DNA. So if it gets mutated, this process gets damaged, and the patient will have a high risk of malignancy. And apart from the proto-oncogene and the tumor suppressor gene, the other important genes which are not in colorectal cancer is MMR gene, which is nothing but mismatch repair genes. What are these MMR gene? Is basically their caretaker gene. What happens whenever there is a DNA synthesis, there will be some DNA replication errors. So these DNA replication errors are corrected by this mismatch repair genes. So what are these genes? There are so many genes. There is MLH1, there is MSH2 or MSH3. All these three-letter genes along with one number or all which starts with the M and which have M in their name or all MMR genes. So how much percentage of colorectal cancer occurs by MMR mutation? Remember, I told you there are two common hereditary colorectal syndrome. One is FAP and other is HNPCC. So out of FAP and HNPC, FAP and HNPCC, which is most common? Can anybody tell me? Out of FAP and HNPCC, which is most common in hereditary colorectal cancer? HNPCC, wonderful. So HNPCC, basically the exact percentage is 3%, whereas FAP happens in only 1% of the hereditary colorectal cancer. Fine. So that's what is going in the next line. The 3% of colorectal cancer occurs by MMR mutation. Okay. So what does MMR gene mutation mutation results? It causes errors in S phase when DNA is newly synthesized and copied. Basically, the DNA replication errors are not corrected because of the mutation in the MMR genes. So how much percentage of sporadic tumors have MMR mutation and how much percentage of HNPCC have a MMR mutation? So as we all know, HNPCC mutation, MMR gene mutation is the most common, and about 95% of patients with HNPCC have MMR gene mutation, whereas sporadic tumor, only 10 to 15% have MMR gene mutation. So remember, even in sporadic tumors, up to 10 to 15% have MMR gene mutation. Fine. So next comes to the adenoma, carcinoma, and sequence. So why we should remember this? Whenever you see a colorectal polyp, even if the biopsy comes as adenoma, you should always consider the adenoma as a pre-malignant lesion to carcinoma, and you should analyze the histology and based on the histological features, you should take a call whether the patient needs a proper surgical resection of the affected segment of the colon. So how do you decide on that? It basically depends upon the histological feature of the adenoma. So what is it? There are three types of adenomas. So I'll see this. These are the three types of adenomas. One is the tubular adenomas. Next is villus adenomas. Next is tubulovillus adenomas. So what is this tubular adenomas? It's basically on histology that you can see a lot of tubular glands in this tubular adenomas. So this is the most common type of adenomatous polyp, which is around 65 to 80%. The next common is a mixture of both tubular adenoma and villus adenoma, which is 10 to 25%. And the least common is a villus adenoma. So villus adenoma, basically on histology, the tumor appears, the polyp appears like with a lot of finger-like projection, like a villus present in the ileum. Fine. So what is given is the tubular adenoma is usually pedunculated, and the risk for cancer in tubular adenoma smaller than 1 centimeter is diameter is less than 5%. So the tubular adenoma, which is less than 1 centimeter, has a very low malignancy risk. At the same time, the risk for carcinoma in a tubular adenoma larger than 2 centimeters, 35%. So tubular adenoma per se doesn't mean that it is a very benign lesion. It also depends on the size of the lesion. So if the tubular adenoma is larger than 2 centimeter, the risk of malignancy is about 35%. So this is an important statistics which is given in all basic textbooks, right from pathology till subhiston. It's also given in subhiston as well as in Bailey. Okay, so remember this point. The tubular adenoma, which is smaller than 1 centimeter in diameter, the risk of malignancy is less than 5%, whereas if the tumor size is larger than 2 centimeter, the risk of malignancy is 35%. At the same time, in short, they say that villus adenoma has a higher malignancy risk. Also, how much is that? The villus adenoma larger than 2 centimeter carries a 50% chance of containing cancer. So the more villus the tumor, the higher the chance of malignancy. The more tubular the tumor, depending upon the size, the malignancy risk varies. Fine. I already explained about this slide, where about the division of the colorectal adenomatous polyps into tubular, villus, and tubulovillus. Which is more common? It is tubular adenomas, followed by tubulovillus, followed by villus adenomas. So what do you do? Also, the tubular adenoma and villus adenoma, see the difference? Mostly tubular adenomas are pedunculated, whereas villus adenoma are sessile. Also, as I said before, the ATPI is always less in tubular adenomas, whereas villus adenomas are severe ATPI is common in villus adenomas. This is in general thumb rule. So how do you treat a colorectal polyp? You have to do a colonoscopic polypectomy. And after the colonoscopic polypectomy, you have to make sure you analyze the histology of the tumor and analyze the depth of invasion of the of the ATPA or malignancy, whatever it is. So how do you analyze the depth of invasion of the tumor? It is done by this Haggett's classification. Okay. So what is this Haggett's classification? So you see this first slide. This is a pedunculated adenoma. So you see this first. So what happens? This colored area are all malignant cells. The colored area are malignant cells. So they are divided into 5 levels, which is level 0, level 1, level 2, and level 3, and level 4. So level 0 is basically an intramucosal carcinoma. So this is level 0. So level 0 is basically intramucosal carcinoma in which the tumor doesn't cross the muscularis mucosa. What is muscularis mucosa? So this part is muscularis mucosa. If it invades the muscularis mucosa, it becomes an invasive cancer. As long as it's within the muscularis mucosa, it is just an intramucosal carcinoma. So level 0 invasion means it's just an intramucosal carcinoma. Level 1 means it becomes an invasive cancer because it invades the muscularis mucosa. So what is level 1? Level 1, it invades the muscularis mucosa at the head of the tumor. Level 2 invades the muscularis mucosa in the neck. Level 3 invades the muscularis mucosa in the stalk. And level 4, it invades the muscularis mucosa and reaches the submucosa. So level 4, it reaches the submucosa. This is what Haggett's classification. So it depends upon the depth of invasion. The pedunculated adenoma has 5 levels. Whereas in sessile adenoma, there are only 2 levels. One is level 0. Level 0 is basically an intramucosal carcinoma, where the tumor is confined. This is the muscularis mucosa here. This is the muscularis mucosa here. So in sessile adenoma, there are only 2 levels. Level 0 is intramucosal carcinoma. And once it pierces the muscularis mucosa and reaches the submucosa, it is level 4. So directly it becomes a level 4 in sessile adenoma because it doesn't have a stalk like a pedunculated adenoma. So this 5 levels base is called as Haggett's classification. It differs between a pedunculated adenoma and sessile adenoma. How it differs, I told you, in a pedunculated adenoma, level 0 is basically an intramucosal carcinoma. Level 0 is basically intramucosal carcinoma. This is the muscularis mucosa. Once the tumor cells invade the muscularis mucosa, depending upon which part of the stalk it invades, level 1 in the head of the stalk, level 2 it is the neck, level 3 it is the stalk, and level 4 it invades into the submucosa. So all is level 1, 2, 3, 4 are invasive cancer because it invades the muscularis mucosa, whereas level 0 is intramucosal. Whereas in sessile adenoma, there are only 2 levels because it doesn't have a stalk. Level 0 is intramucosal, and once it invades the muscularis mucosa, it comes to submucosa where it becomes level 4. Okay, let's go to the previous slide now. So as I said before, any colorectal polyp treatment is colonoscopic polypectomy. So a pedunculated polyp with invasion to level 1, 2, and 3 has a low risk for lymph node metastasis or local recurrence, and complete excision of the polyp is adequate. So that is, if the depth of invasion is less, that is level 3, that is, if the depth of invasion is confined only to the stalk, the risk of lymph node metastasis is very less, and you can just leave off with the colonoscopic polypectomy. Whereas if the depth of invasion is going till the submucosa, there is a risk of lymph node involvement, and in that case, you need to go for a bowel resection. At the same time, see the next point, a sessile polyp containing invasive cancer has at least a 10% chance of metastasis to the regional lymph nodes always. So that is why most commonly sessile polyp, when after resection, if it has invasive cancer, it's better to go for bowel resection because it has a high chance of lymph node metastasis. And the last one, this is the point which I reiterated when I showed that picture. Invasive carcinoma describes a situation in which the malignant cells have extended through the muscularis mucosa of the polyp, whether it is on a stalk or a sessile lesion, which I explained you clearly in the picture explaining the Haggett's classification. Are you thorough with the, are you clear with the Haggett's classification and how you manage the adenomatous polyp based on this? Any doubts on this?
No, sir.
No, sir.
Fine, fine. Fine. If you're clear with this, I'll go ahead. Fine. So remember, there are 5 levels on a pedunculated adenoma, but for a sessile adenoma, there is only 2 levels. So level 0, and as soon as it invades muscularis mucosa, it becomes level 4. Fine. Sessile adenoma. So answer this question. Sessile adenoma with the muscularis mucosa invasion belongs to which Haggett's level? Level 0, 1, 3, 4.
B.
D. Yeah, level 4. Wonderful. So the answer is D, level 4. As I said before, is everybody okay with this? I mean, is everybody understood this answer?
Yes, sir.
Yeah, fine. Anybody wants to explain about this? Because it's a very important thing. It will definitely, they might ask about this Haggett's classification. So hope you're clear with the levels. Fine. Fine. Okay, I'll go ahead. Okay. So I'll go fast because I want to cover a lot, and because basically this is a general surgery class. So basically I'll brush up the concepts. Whichever area you feel your concepts are not good, you stop me. I'll explain the concept. Fine. So the other important polyps which is given in substance is the hyperplastic polyps. And they say this is the most common colonic polyps. Hyperplastic polyps are the most common colonic polyps. So whenever they ask about which is the most common colonic polyp, it is not adenomatous polyp. It is hyperplastic polyps. And these are usually very small diminutive polyps, and they doesn't have malignant potential. And how does it appear in histology? It has a serrated or sawtooth appearance. But also remember, they are given adenomatous changes can occur in hyperplastic polyps and results forms a serrated adenomas. So what is serrated adenomas? What is the peculiar feature is? There are 3 peculiar features. It is more common in the right side of the colon, number 1. Frequently occurs in the older women, number 2, and smokers. So hyperplastic polyps typically have a serrated or sawtooth appearance. They don't have malignant potential at all, but sometimes, very rarely, adenomatous changes can occur, forming a serrated adenomas. And what is the peculiar feature of serrated adenoma? Occurs in right side, older women, and smokers. Fine. So this is a nutshell of the various hereditary colorectal polyposis syndrome. This table is given in Shackelford. Also, there is a very elaborate table given in Saveston. I somehow feel you should keep looking at the table often so that you will remember the most important points. At least you should know what is the gene affected and what are the important feature of that is hereditary polyposis syndrome. Out of which the most important you must remember is the familial adenomatosis polyposis and HNPCC, hereditary non-polyposis colorectal cancer syndrome, which is the Lynch syndrome, and the third is pure Jagger polyposis. These are the three important things which you must remember. You should know what gene is affected, in which chromosome the gene is present, and what are the which part of the GA tract or extraintestinal malignancy the particular mutation can lead to, and whether it follows an autosomal dominant pattern or a recessive pattern, and some other interesting or peculiar feature which is present in that particular syndrome. So if you see this table, most of the syndromes have an autosomal dominant inheritance, except this muti-associated polyposis. It is also called as MAP or NTHL1 associated polyposis. So this M associated polyposis and N associated polyposis both have a recessive mutation. Fine. So this is the one important thing you must remember. Whereas most of the other things, familial adenomatous polyposis, the Lynch syndrome, all the other things have an autosomal dominant mutation. Okay. And along with that, make sure you remember the gene involved in all this hereditary polyposis. So you keep looking at the table. Sebastian has a very elaborate table for 2 pages. It's better to look at have a look at the Sebastian table for an exam purpose. Fine. So as I said before, I have been repeatedly saying the two most common is FAP and HNPCC, out of which HNPCC is the most common 3%, whereas FAP is the next the least common, is around 1%. Fine. So I'll tell you the cardinal features of FAP, which you must remember. So the FAP is basically familial adenomatous polyposis, which there is presence of multiple colonic polyps. More than 100 colonic polyps is a diagnostic feature. Sometimes it might be in 1,000 scattered throughout the colon. Also, it's not only in the colonic polyps, the polyps may also be present in gastric, duodenal, and periampullary area. Out of which, remember that this gastric polyp is basically hyperplastic fundal glands. So they do not have a malignant potential. Whereas this duodenal polyps or adenomatous polyps, so they have malignant potential, and they might lead on to form a duodenal adenocarcinoma, and sometimes it can form a periampullary polyps, which can form an ampullary carcinoma. So gastric polyps is basically hyperplastic fundy glands. They don't have malignant potential, whereas a duodenal polyp and a periampullary polyps, they have a pre-malignant potential there because they are adenomatous polyps. Apart from this, they also have extra intestinal manifestations. So what are the extra intestinal manifestations? They have epidermoid cysts. They can have desmoid tumors in the abdomen, which is a mess to manage. They might have osteomas, and they might have brain tumors. As I said before, gastric and duodenal polyps occurs in approximately 50% of affected individual. Always remember, gastric polyps are basically fundy gland hyperplasia, and they do not have malignant potential. Whereas duodenal polyps are always adenomatous polyps, and they are pre-malignant. That's why in FAP patient, along with colonoscopic surveillance, we also should do an upper GI endoscopy with a side viewing scopy to look at the ampulla as well as the duodenum to look for any adenomatous polyps. Fine. Okay. And as I said before, the incidence of FAP is only 1% of all colorectal cancer. It's caused by a germline APC mutation. I told you before, APC mutation is a tumor suppressor gene. Remember, RAS is the only proto-oncogene in the multi-step carcinogenesis model. All others are tumor suppressor gene. And it follows autosomal dominant inheritance. Only thing which follows the autosomal recessive is the muti-associated polyposis and another NTLH1 associated polyposis. Okay. 100% penetrance. What is this 100% penetrance means? If the patient has an APC mutation, he will definitely have familial adenomatous polyposis. Fine. So that's why genetic testing is for APC mutation is required at puberty if the patient has a family history of familial adenomatosis polyposis. The clinical diagnosis is made on colonoscopy. If more than 100 polyps, as I said before, 80% chance of APC mutation. At-risk family members should all be screened, because 50% of the person affected with in the family affected with the APC gene mutation will have a offspring with the affected gene. And the most common cause of death in FAP is a colorectal cancer. Okay. So when does the FAP? When does the median cancer starts in the median in familial adenomatous polyposis? The median age of cancer is 39 years. See, this is a median age for cancer onset is 39 years. But what is the age for polyp onset? The polyp usually starts in the second decade of life. Okay, second decade of life. Second decade, the polyp start around 17 years. The polyp starts at this age. Polyp starts at this age. And as I said before, in FAP, the tumor progression is very slow, whereas only in HNPCC, the tumor progression is very rapid. So in FAP, the polyp starts at the second decade, around 17 years of age, and it takes around 3 decades, that is around only 39 years of age, it becomes a malignancy. So the average age in which you can find malignancy in FAP patient is around 39 years. Fine. So remember this. So all these concepts can be integrated in this. Median age for cancer is 39 years in classic FAP. Cancer is 39 years. The polyp onset is in the second decade of life, which is approximately around 17 years. Fine. So most effective way of treatment in a patient with suspected FAP, there is 100% chance of colorectal cancer. In HNPCC, there is 70 to 80% cancer risk, whereas FAP, there is 100% chance of cancer risk. So the most effective way of treatment for these patients is prophylactic colectomy. Okay. So if not planned for surgery, you have to do, if the patient is a young patient for whom you don't want to do a morbid surgery, in that case, you have to do an annual surveillance with polypectomies for larger polyps until surgery starting at 10 to 12 years. Fine. So from 10 to 12 years, you should start an annual surveillance colonoscopy if you are not planning for the prophylactic total proctocolectomy. Again, all patients with FAP will have fundy gland polyps and duodenal adenoma. And the most common cause of death, as I said before, is colorectal cancer, followed by desmoid tumors, followed by duodenal adenocarcinoma. So this is the sequence which is given in Shackelford. The most common cause of death is colorectal carcinoma, followed by desmoid, followed by duodenal adenocarcinoma. And that is why to rule out duodenal adenocarcinoma, we have to start along with the colonoscopic surveillance. We have to do an OGD plus side scopy starting from 20 to 25 years of age. So whenever there is a risk of desmoid, you have to defer surgery as much as possible, because when the patient is having a risk factor for high risk desmoid tumor formation, the more surgical trauma, the more advanced, advanced and more severe the desmoid tumor formation will be, and better to defer surgery in these patients who are at high risk factors for desmoid tumor formation. So what is this? What is this thing? This is basically a congenital hypertrophy of retinal pigment epithelium, which is typically present in FAP, and almost 75% of individuals with FAP have this finding on indirect ophthalmoscopy. Okay, remember 75%, which is 3/4 of the patients with FAP have congenital hypertrophy of retinal pigment epithelium. Fine. So let's do this MCQ. Identify the false statement regarding FAP. The gene is expressed in 100% of patients with the mutation. True or false? True. Wonderful.
True.
Okay. So, yeah, as you all know, the FAP gene mutation has a 100% penetrance. Therefore, the gene is definitely expressed in all patients who show the mutation. Fine. The autosomal dominance results in expression in 50% of offspring. True or false? Yeah, obviously, if there is a dominant mutation, 50% of the offsprings will be having the expression. Fine. So that is also true. All patients affected with the FAP have a positive family history. True or false?
False.
False.
False. Yeah. False. As I said before, up to 30% of patients with FAP do not have a positive family history. And why they don't have a positive family history? Because that might be because of a de novo germline mutation of APC, which happens in those people. Okay. The average age of a patient who's newly discovered to have colorectal cancer and FAP is 39 years. True or false?
True.
True. As I said before, polyp formation in the second decade, cancer formation at 39 years, and cancer is 100%. Therefore, the treatment of these patients with FAP is prophylactic proctocolectomy with alveolar pouch anal anastomosis. Fine. So that is the false statement. So treatment of FAP, always remember the entire colon and the rectal mucosa is at risk of a malignant transformation. Therefore, you can't keep that, and it's 100% risk for a conversion into a colorectal malignancy. Therefore, you have to take out the entire colon and rectum along with the anorectal mucosectomy. Therefore, restorative proctocolectomy with alveolar pouch anal anastomosis is a surgery for FAP. So this is the same surgery which is also used for ulcerative colitis. How does it differ? I'll tell you. I'll tell in the further slides. So the same surgery which is done for ulcerative colitis, you form an ileal pouch and anastomosis to the anal canal. Always remember, the more you dissect in the rectum, the more morbid the surgery, because of the pelvic dissection in a young individual. There might be damage to the autonomic nerves that which might result in infertility and other genitourinary complication, which is definitely a morbid thing for a young patient. If you want to avoid a pelvic dissection, what you can do, you can just do a subtotal colectomy, that is abdominal colectomy, and you can do an ileorectal anastomosis. And once the patient has completed the family, you can go ahead and do a completion proctectomy. So that is another way of managing. But the treatment of choice is restricted proctocolectomy with IPAA. You can make a choice of preserving the rectum in case of young individuals who want to preserve the fertility, because if you do a proctectomy, there are high chance of pelvic dissection might result in autonomic nerve damage and might result in infertility. So you understood this concept, right? Can I go ahead?
Yes,
Hello.
sir.
Yes.
Yeah, fine. So always, like in ulcerative colitis, there are two options. You can do either an hands-on anastomosis. The ileal pouch channel anastomosis can be either hands-on or staple. Whereas in FAP, it's always better to do an anorectal mucosectomy, because there might be the malignant change of the if you leave any rectal cuff. Cuff. So if you do a staple anastomosis, definitely some part of rectal cuff might be retained. So it's always better to do an anorectal mucosectomy so that all the mucosa which has a malignant risk is completely removed, and then you can do an hands-on anastomosis at the level of dentate line, so that completely there is no mucosa left which can be converted into which can undergo a malignant change. So always remember, IPAA is patient between the ileal pouch and dentate line of the anal canal. So you do an anorectal mucosectomy, and then you do a ileal pouch patient between the ileal anastomosis between the pouch and the dentate line of the anal canal. So how does the pouch in FAP differ from the pouch in IBD? Pouch in FAP have better functional results. That is in terms of incontinence. That is in terms of the other the need to self evacuate. All are better in case of a pouch considered in a patient with FAP. And there is very much lower incidence of pouchitis in patients with FAP when compared to ulcerative colitis. Fine. So in short, the treatment of FAP is total abdominal colectomy and ileorectal anastomosis in young individuals with a low rectal polyp burden. Otherwise, the treatment of choice is always a prophylactic total. Why prophylactic? Because you are going to do the surgery before the patient has developed any malignancy. So you are going to do a prophylactic total procto TPC, total proctocolectomy with ileal pouch anal anastomosis. And always remember, in FAP, you have to do a anorectal mucosectomy. Some say that the anorectal mucosectomy can be avoided if the tumor is not present in the lower third of the rectum. If the tumor is present in the lower third of the rectum, you can do anorectal mucosectomy. If it is not present in the lower third of the rectum, you can avoid this anorectal mucosectomy and you can do a stable anastomosis, because the anorectal mucosectomy better has, in terms of functional results, it's poor when you do anorectal mucosectomy. So they say based on the rectal polyp burden, if there is a high load of rectal polyp in the lower third of the rectum, better to do a anorectal mucosectomy. And if the lower and mid rectum is completely free of polyps, then you can actually avoid anorectal mucosectomy and do a staple anastomosis. Always, as I said before, in young individuals, you can avoid do a proctectomy. You can come and do a proctectomy in the future once he has completed the family, so that the risk of fertility is not affected. And remember this, based on the mutation, you can also predict the risk for rectal cancer. The risk for rectal cancer is 3 times higher in FAP patient with a mutation after codon 1250 than in patients with a mutation before this codon. So always remember, as I said before, the codon, that mutational cluster region, which is 1250 to 1464. So these are the patients who have classical FAP. That means the patient have plenty of polyps scattered throughout the colon. And these are the patients who are also at high risk of having rectal polyps along with colonic polyps. So these are the two drugs which have been used for example, if the patient doesn't have rectal polyps and you want to preserve the rectum, you can do just an abdominal colectomy and start this patient on these NSAIDs, which has been hypothesized to decrease the formation of a polyps in this FAP patient, which is celecoxib and sulindac. But even then, 1/3 of patients always who are treated by abdominal colectomy and ileorectal anastomosis develop florid polyposis of the rectum, and they will ultimately require proctectomy and endoleostomy within 20 years, which is around 1/3 is basically 30% of patients. So even if the rectum is not involved and you're doing only a total abdominal colectomy and ileorectal anastomosis, 30% of that patient will ultimately progress to completion proctectomy. Fine. So this is how the treatment of a FAP is. The treatment is always prophylactic, total proctocolectomy with the ileal pouch anal anastomosis. Always anorectal mucosectomy is included with it. You can skip an anorectal mucosectomy if the polyp burden in the rectal polyp burden in the lower third of the rectum is less. In young individuals, if the rectal polyp is not present or if the rectal polyp burden is very low, you can do a total abdominal colectomy and ileorectal anastomosis and keep the patient under surveillance. Who are the patients who have more risk for rectal cancer is these patients who have mutation in the mutation cluster region, which is the mutation after the codon 1250. Okay, these are all the points which is given in subdistant. Don't think these are all high points. Okay, and the last point important is even if you do abdominal colectomy ileorectal anastomosis, even in a completely normal rectum patient, ultimately the patient will require a proctectomy in 20 years. So the next important thing in FAP is the desmoid tumor. As I said before, there are the three most common cause of death. First is colorectal cancer, followed by desmoid tumor, and followed by periampullary carcinoma. So what is this desmoid tumor? Desmoid tumor is basically a proliferation of the fibrous tissue, which is a kind of a locally aggressive tumor, which happens in 30% of FAP patients. So where does it occur? This is most common in the abdominal wall, which can be managed. But if it happens in the small bowel, mesentery, retroperitoneum, it's sometimes very messy because the dense fibrosis and the puckering and the fibrosis associated contraction of the mesentery might involve even the vessels. It can compromise the vascular supply of the vessel. It can cause the fibrosis along the ureter because of the retroperitoneal involvement. So, and even if you resect, it will again come back come back more aggressively. So it's not a very easy thing to operate on desmoids. So that is why desmoids is the second most common cause of death in FAP patients, followed by colorectal cancer. So it can grow rapidly. It sometimes be fatal because it can cause intestinal obstruction, ureteric obstruction. It can cause EC fistula. So what are the risk factors for desmoid? It happens in females, patients who have family history of desmoids, patients who have a Gardner syndrome, and the genotype also matters. Mutation 3' prime end of the codon 1500 have high risk for desmoid. So how to manage desmoid as much as possible? You should avoid a conservative only. Surgery should be done only for complications or symptoms. And this is a Church stating which is given in Shackelford. There are 4 stages based on the size of the desmoid, based whether it is symptomatic, based on whether the growth in interval growth, and based on the stage, you can give appropriate treatment, which can be in the form of Sulindac till the extent of chemotherapeutic agents like methotrexate, sorafenib, or adriamycin. So for a stage 4, which is a larger size with symptomatic and interval growth also is more, in that case, you might have to use a doxorubicin or adriamycin. Fine. So surgery for desmoids is usually not contemplated. As much as possible, you have to do a conservative management, because even if you do a surgery, there will be local recurrence rate of 33% and less often resectable, because mostly they arise from mesentery and retroperitoneum. They are not well-defined tumors. They are diffuse. Unless if you are seeing a desmoid, when you can't get any planes at the same time, it will be a very massive surgery, because it's going to infiltrate the root of all the mesenteric vessels. It will infiltrate the retroperitoneal structure. So you may not be, you may not be able to get a plane to resect, to clear-cut plane to resect the desmoid tumor. Fine. So the surgery for desmoids is, apart from the surgical management, there are other modalities, but they are not very fruitful. Radiotherapy can be given. Sometimes a patient has been treated with a tamoxifen, like hormones like tamoxifen and raloxifen, but not very fruitful. Okay, so these are the important points about FAP. Now come to the next common, the other common hereditary colorectal cancer syndrome, which is HNPCC, which is 3% of all cases of colorectal cancer. So the cardinal feature of HNPCC is, so these are the important thing of HNPCC associated colorectal cancer is the onset, where in FAP it is 39 years, in HNPCC is 44 years, okay, which is younger than the age group of sporadic colorectal cancer. And almost all the HNPCC associated cancer happens in a proximal distribution. That is almost 70% occurs in the right side colon. And the predominance of mucinous or poorly differentiated or signet ring cell adenocarcinoma is a typical feature of HNPCC. Also, there is increased number of synchronous and metachronous cancers. And despite all these poor prognostic indicators, what are the poor prognostic indicators? All these mucinous, poorly differentiated signet ring cell, and increased number of synchronous and metachronous cancer, they have a relatively good outcome after surgery. Fine. So what are this HNPCC associated? How do you diagnose a patient? It's based on clinical criteria. We have 2 criteria. Initially, it was given as Amsterdam criteria. So later it was modified to modified Amsterdam criteria. What is this Amsterdam criteria? Amsterdam criteria included only colorectal cancer. So what is this? There should be one affected person. One affected person is a first degree relative of the other 2 affected person. 2 successive generations should be affected. and at least one case of colon cancer should be before the age of 50 years, and FAP should be excluded in these patients. So this is the Amsterdam criteria, but they found that colorectal cancer is not the only malignancy which is present in HNPCC. They also found that the other important malignancies like endometrium, which is the next common cancer in HNPCC, small bowel, ureter, and renal pelvis, or the other extraintestinal cancers present in HNPCC. So that also should be included along with the Amsterdam criteria, and that's why it became the modified Amsterdam criteria. So remember this Amsterdam and modified Amsterdam criteria, and people who fit into this criteria, they are suspected to have HNPCC, and they can be tested for mismatch repair gene mutation. Okay. So what is the Bethesda criteria? Bethesda criteria is basically the categorizes the people if the Bethesda criteria is fulfilled, these patients might undergo an MMR gene testing to look for HNPCC. So what are the things? It's the same thing. The Amsterdam criteria, like 2 cases of HNPCC in one patient, including synchronous and metachronous cancer. So all the features of HNPCC, if the patient has been summarized in a Bethesda criteria, and if the patient fits into this criteria, they should be tested for MMR gene mutation. So Amsterdam criteria, modified Amsterdam criteria, and all this Bethesda criteria have been used to test the patient for HNPCC by an MMR gene mutation. So what is this mismatch repair gene mutation? I already told before, these are the important genes, out of which these 2 genes, MSH2 and MLH1. I don't think you should remember the chromosome of these things, but at least remember this, the genes which starts with the M and which has a number at the end are all mismatch repair genes. Okay. So the mismatch, the more than 90% of mutations of the mismatch repair gene happens in MSH2 and MLH1. So other genes, mismatch repair genes are MSH6 and PMS2, and there are a lot of peculiar factors associated with each gene. But remember, in substance, these are the 2 important things just given. More than 90% of mutations happens in MSH2 and MLH1, whereas MSH6 is associated with endometrial carcinoma. As I said before, next to colorectal cancer, the other, they are also HNPCC patients are more prone for developing endometrial carcinoma, and such patients have typically high rate of MSH6 mutation, MMR gene mutation. Fine. So how do you do a surveillance in patients with suspected HNPCC or a proven HNPCC mutation? I said before, in FAP, since the tumor progression is slow, you can do a colonoscopy at the interval of 3 to 5 years. Whereas in HNPCC, as I said before, the tumor progression is very rapid, and hence the colonoscopy should be repeated every 2 years until the age of 35 years, starting from the age of 20 years. So start the colonoscopy at the age of 20 years. Since the tumor progression is very rapid, you repeat at the shorter intervals when compared to FAP. That is, every 2 years, you should repeat the colonoscopy until the age of 35 years. Along with that, since the patient will also have a endometrial carcinoma risk, also start doing periodic vacuum curettage at age 25 years, along with pelvic ultrasound, and also do a CA-125 levels to look for any ovarian carcinoma. Also, since there is high risk of cancer in the renal pelvis and the ureter, look for occult blood and urine annually. So these are the surveillance which you have to do for HNPCC patients. Fine. So in FAP patient, you have to start colonoscopy at 10 to 12 years of age, and then you can repeat the colonoscopy at an interval of 3 to 5 years because tumor progression is slow in FAP. So if there is no tumor in colonoscopy, you can repeat at a much wider interval. Whereas in HNPCC, you start the colonoscopy at 20 years. Since the tumor progression is very rapid here, you have to repeat colonoscopy at very short intervals every 2 years until the age of 35 years. Fine. And along with that, also look for other extraintestinal cancers. Like in FAP, you're looking for endoscopy to look for duodenal adenomas. Same thing in HNPCC, you have to look for endometrial carcinoma risk by looking for an ultrasound and the endometrial thickness, the CA-125 levels, and also look for rule out any cancer in the renal ureter and the renal pelvis. So what is the treatment of colorectal cancer in HNPCC? It's always abdominal colectomy, and ileorectal anastomosis is the procedure of choice. So here the rectum involvement is not very common like in FAP. As I said before, in HNPCC, the most common segment of colorectum which is involved is the right side of the colon. The right side of the colon is the most common segment which is involved. So the best surgery for these patients will be to do a total abdominal subtotal colectomy with ileorectal anastomosis. So FAP, the treatment of choice is prophylactic total proctocolectomy with ileal port channel anastomosis. Whereas in HNPCC, the surgery of choice is abdominal colectomy with ileorectal anastomosis. But always you should make sure that the surveillance, the rectum should be under surveillance to look for any pre-malignant or malignant lesions. Okay. And since the patient has also have an endometrial carcinoma risk, and if the patient has completed family, TH and BSO can be completed along with the initial surgery. Fine. So I think the two most common symptoms I have covered. I think I have to go fast. Fine. So Peutz-Jeghers syndrome is another important colorectal cancer syndrome, which is basically characterized by an hematomodous polyps. So remember, this is also an autosomal dominant. Okay. So most of these autosomal dominant, except two things which I said before, MAP associated, MUTI associated polyposis have an autosomal recessive inheritance. So Peutz-Jeghers syndrome is characterized by hematomodous polyps and hyperpigmentation of the buccal mucosa. What is the gene which is involved? STK11 gene. Okay, this is also tumor suppressor gene. Okay, and increased risk of cancer, and it is along with the hematomodous polyps. It also has the extraintestinal malignant neoplasm like breast, ovaries, cervix, fallopian tubes, thyroid, lung, gallbladder, like a wide variety of extraintestinal malignancy risk of Peutz-Jeghers syndrome. Fine. Juvenile polyposis syndrome is because of SMAD4 gene mutation. So Peutz-Jeghers gene, Peutz-Jeghers, hematomodous polyps, and STK11 gene mutation. Juvenile polyposis is another tumor suppressor gene, which is SMAD4. Okay. This also has predominantly hematomas, whereas, but the important thing is the hematomatous polyps of juvenile polyposis can cause hypoalbuminemia because of the protein loss associated with the polyps. Fine. Fine. So as far as this is as the most important things regarding the colorectal polyps. Now let me brush through the concepts. I won't be telling in detail about colorectal cancer management, but I'll brush through fastly about the important concept regarding the management of colorectal cancer. Fine. So the symptoms of colon cancer differs between a right side colon cancer and a left side colon cancer. So in a right side colon cancer, always the lumen is larger and the contents are more semi-solid. So that's why the right side colon cancer doesn't go for obstruction. And how do they present the right side colon cancer? They present as non-specific symptoms, and sometimes they will present as because of blood loss. They can present as iron deficiency anemia, and sometimes if there's an advance, they can present as a mass. So an elderly male patient with an iron deficiency anemia, you must investigate for a colorectal, the right side colonic malignancy, and before along with the treatment directed for iron deficiency anemia. Okay. The left side colon, on the other hand, the lumen is narrower when compared to the right side, and the contents are more solid, and the growth also in left side colon is more constricting. So it's a constricting growth in a left side colon. Therefore, it goes more commonly for obstruction. That's why altered bowel habits and obstruction are more common in the left side colon. So how are you going to investigate these patients? First, the most common is the carcinoembryonic antigen. The tumor markers should be done in all these patients, and you must do a full colonoscopy if the tumor is not obstructed. So why you do a full colonoscopy? There is a chance of 30% chance of synchronous lesion and 3% chance of synchronous cancer. Is a very important number. 30% chance of synchronous lesion, 3% chance of synchronous cancers. So if obstructed, in that case, you can't do a full colonoscopy. In that case, you have to do a colonoscopy within 6 months of the surgery. Fine. So even if you're not able to do a full colonoscopy, you can do a colonoscopy within 6 months of surgery. And along with that, CT scan of the chest and abdomen to look for liver and lung mets. PET CT doesn't have a role in initial evaluation for colorectal cancer. So this is the AJCC 8th edition. This is the recent edition of a TNM staging. All the TNM staging you must know, especially the gastric cancer, the colorectal cancer is very important. And I feel you should put it in a paper and stick it in your wall and look at it every day so that you are very thorough with it. Fine. So in short, T1 invades submucosa, T2 invades muscularis propria. I'll just brush through very fast. So T3 means it invades submucosa into the peritonealized, pericolic, and perirectal tissues. T4 invades perforates visceral peritoneum, and T4B invades the adjacent organs. Let's come to the end stage. N1, 1 to 3 regional lymph nodes. N1 is further has, so the N1A, N1B, N1C. N1A is 1 node, N1B is 2 to 3 node, or N1B can be a tumor deposit that is satellites in the subserosa, or in non-peritonealized pericolic or parietal surface. So this is N1C. N1A is 1 node, N1B is 2 to 3 nodes, N1C is basically tumor deposits or satellites in the subserosa or a non-peritonialized pericolic or perirectal soft tissue without a regional lymph node metastasis. N2, 4 or more regional lymph nodes. N2A is 4 to 6. N2B is 7 or more. So this is how the recent TNM staging of colorectal cancer is, which is very important. This you must know along with the TNM staging of gastric cancer. Very commonly they are asked. So as far as metastasis is concerned, M1 has further M1A, M1B, and M1C. What is M1A? Metastasis is confined to one organ, which can be anything like liver, lung, ovary, non-regional lymph nodes without peritoneal metastasis. For example, for a colonic right single colonic cancer, para-aortic node is a non-regional lymph node. Okay, whereas ileocolic node is a regional lymph node. So M1A, para-aortic node involvement is M1A. M1B metastasis is more than one organ. M1C is metastasis to the peritoneum with or without other organ involvement. So M1C peritoneum involvement is M1C. Fine. Also, in the biopsy, especially in a patient who has metastatic colorectal cancer, you should test for KRAS mutation. As I said before, KRAS mutation. Why is it important? Patients who have KRAS mutation, they can be treated with patients who have KRAS mutation cannot be treated with antibodies directed against the EGFR receptors. What are these three drugs? There are two drugs, which is cetuximab and panitumumab, which are used, which are basically EGFR inhibitors, epidermal growth factor receptor inhibitors, which is used in a metastatic colorectal cancer setting. So, but patients who have KRAS mutation, these drugs won't act and should not be used in patients with KRAS mutation. So remember, KRAS mutation status should be checked for every colorectal cancer in the biopsy specimen, especially if the patient is having a metastatic tumor. Why? Because that will dictate your treatment policy in the form of whether you can give EGFR inhibitors like cetuximab and panitumumab. So what surgery you do for colorectal cancer is basically this small tumor located in the ascending colon or cecum or right side of the colon. You go ahead and do a right hemicolectomy. Okay, you go ahead and do a right hemicolectomy. Right hemicolectomy. So what are the things you ligate? You ligate the ileocolic, you ligate the right colic, and you ligate the right branch of the middle colic. That is right hemicolectomy. For a tumor which is located in the transverse colon, you can do either a transverse colectomy or you can do either, depending upon whether it is involving more on the right side or the left side, you can do a right extended or a left extended hemicolectomy. But transverse colectomy can be done for a tumor which is located in the transverse colon. For a tumor which is located almost in the descending colon, left hemicolectomy. For a tumor which is located in the sigmoid, you can just go ahead and do a sigmoid colectomy, but make sure you do anastomosis in the vascular part of the descending colon. As far as rectum is concerned, for the tumor which is above the peritoneal reflection, you do an anterior resection. For a tumor which is below the peritoneal resection, you do low anterior resection. For a tumor which is very close to the anorectal ring, but is more than 1 centimeter from the anorectal ring, you do an ultra low anterior resection. For a tumor which is almost in the anal verge, or the tumor which involves the sphincter complex, you do a APR. So these are the various surgeries which is done for colorectal cancer. And apart from that, the surgery doesn't mean that you have to remove only the bowel only. You have to also remove the regional lymph nodes along with it. And the most important thing in colorectal cancer surgery is, along with the whatever colectomy you do, either right hemicolectomy or left hemicolectomy, the most important thing is you have to do a CVL. So what is CVL? CVL is vascular ligation. Central vascular ligation. Another important concept is CME, complete mesocolic excision. CME is nothing but complete mesocolic excision. And recently, what another concept has been introduced, like gastric cancer, you do a D2 lymphadenectomy. In colon cancer, the recent concept of D3 lymphadenectomy has come into role. So these are the three important things which are terms which is being used for a colon cancer along with the right or left hemicolectomy to make sure adequate surgical adequate oncological principles are followed to clear the tumor. So what is the central vascular ligation? It means that you don't ligate the pedicles close to the bowel wall. So you ligate the pedicles almost close to the origin. Like the ileocolic, you ligate central vascular ligation, you ligate close to the SMA origin. Fine. Same thing to the right colic as well as the middle colic. What is complete mesocolic excision? The entire mesocolon, that is whatever the mesocolon, the entire mesocolon should be taken. You shouldn't cut the tumor close to the bowel wall. So you should take the entire mesocolon along with it. This is a complete mesocolic excision. So what is D3 lymphadenectomy? I'll show you in a picture, in the next picture. Fine. So this is what the tumor, and after the surgery is done, depending upon the stage of the tumor, you're going to start the patient on chemotherapy. So this is wonderfully summarizes the need for chemotherapy. Always remember, stage 3 tumors needs chemotherapy. Stage 3 tumors, chemotherapy. Whereas stage 2 tumors, stage 1 tumors doesn't need an adjuvant chemotherapy. Only if there is high risk. High risk. What are the high risk? Whether inadequate lymph nodes are removed, poorly differentiated tumor, vascular lymphatic or perineural invasion, obstructed tumor or a perforated tumor, or pathologically it is T4 stage. So all this thing, thing, or a poor high risk stage 2 tumors, in which case adjuvant chemotherapy can be given, which is usually 12 cycles of FOLFOX. 12 cycles of FOLFOX. So adjuvant therapy, all stage 3 tumors receives adjuvant chemotherapy. Stage 2 tumors only if it is high risk, and I will listed what are the high risk features. Fine. This is another latest concept in which shows which patient needs chemotherapy. So it divides. As I said before, stage 3 patients are all high risk. They need adjuvant chemotherapy. So start them on FOLFOX, give them FOLFOX 12 cycles. Okay, but stage 2, you go by whether microsatellite instability is present or not. So if the genotype is microsatellite unstable, in that case, they have low risk, so not give chemotherapy. But if they have microsatellite stable, in that case, you look for the low risk and high risk feature. And if they have high risk feature, you can give chemotherapy. So they have further modified in this paper, like in stage 2 tumors, if there's microsatellite instability, you need not give chemotherapy. Instability means don't give chemotherapy. But if it is stable, give chemotherapy if they have high risk feature, like I said before. So this is another recent concept which has come, how to guide the adjuvant treatment after resection for colon cancer. So this is in a nutshell.
Sir, can you repeat, sir?
Yeah. What do you want? You want to repeat?
Sir, about that stability and instability.
So this basically microsatellite instability is what the genomic analysis we do for colorectal cancer along with the RAS mutation. So you see whether the patient is having a microsatellite stable tumor or unstable tumor. If the patient have microsatellite unstable tumor, then they have low risk for developing either regional or systemic metastasis. We need not give chemotherapy for them. See, remember, stage 3 definitely you have to give chemotherapy. Stage 2 only, they are further divided into two things based on the MSI, microsatellite stable or unstable. Microsatellite unstable, they are low risk for developing metastasis, and such patients need not, you can omit a chemotherapy for stage 2 MSI. For stage 2 microsatellite stable tumors, again, you follow the same principle which you followed in the previous slide. Like if the patient has high risk features, you do chemotherapy. If the patient has low risk features, you can omit chemotherapy. Fine. You understood, right?
Yes, sir. Thank you, sir.
Fine. Thank you. Fine. So, so usually, as I said before, it's better to give oxaliplatin based 5-fluorouracil chemotherapy instead of giving only 5-fluorouracil and leucovorin. And this is how the Annals of Oncology has given the 5-year survival, and how the survival improves by adding adjuvant therapy with FOLFOX or 5-fluorouracil. Okay. So always remember, surgical principle, adequate margins and adequate lymph node clearance is very important for this colorectal cancer. And this is in a nutshell what surgery to be done, which I explained before. And these are the standard resections, which is right hemicolectomy. Depending upon the location of the tumor, you'll be well aware of this. Right hemicolectomy, you should know what vessels are ligated. I feel I need not explain this. You'll be very thorough with this. And other left hemicolectomy, sigmoid colectomy. So depending upon the tumor location, these are the types of surgery which has to be done for the colorectal cancers. And as I said before, three important thing in oncological principles of colorectal cancer treatment is CME, CVL, and D3. I explained about what is CME, complete mesocolic excision. That is, you have to take the bowel along with the entire mesocolon. It's not like only should remove. So your specimen should have the colon along with the entire mesocolon. Then only you have done the surgery according to the oncological principles. Plus, you will do central vascular ligation. So the vessel should be ligated at the origin. Like ileocolic should be ligated at the origin, right colic should be ligated at the origin, middle colic should be ligated at the origin. Central vascular ligation and D3 lymph node dissection. What is this D3 lymph node dissection? I'll tell you here. So this picture shows a D3 lymph node dissection. That is, you have to go to the root of SMA and SMB, and you should be able to, once you do a lymph node dissection, so this boundary formed by this rectangle should be clearly dissected of the lymphatic tissue. At the end of the lymph node dissection, you should be able to see the area, the left lateral border of the SMA, which is coming from the inferior border of the pancreas, plus the dissection should go 5 mm above the origin of the middle colic and 5 mm below the origin of the ileocolic, plus 1 centimeter lateral to the SMA. Okay, so this area, basically, in short, you should be able to see the left lateral border of the SMA at the end of your lymph node dissection for a proper D3 lymph node dissection, which is the recent concept of which is emerging, which is followed by the Japanese for lymph node dissection in colorectal cancers. Fine, like D2 gastrectomy, colorectal cancer also has D3 dissection. So what is D3 dissection? It's basically clearing the lymphatic tissue around the origin of the SMA and SMB. The boundaries in a short is basically you should be able to see the left lateral margin of the SMA and 5 mm above the middle colic, 5 mm below the ileocolic, 5 mm below the ileocolic, 5 mm above the middle colic, and 1 centimeter in the lateral to the SMA and SMB. Fine. So you understood D3 dissection. Plus, also remember the nodes in the regional lymph nodes in colon cancer are further divided into epicolic. Epicolic are basically the nodes on the colon wall. Paracolic are the nodes along the marginal artery. Intermediate nodes are the nodes along the artery supply the colon, and apical are the nodes along the origin of the vessels. So you must remember this prognosis because colorectal cancer is very common, and based on the stage, you should know the prognosis. Stage 1 cancer, 90% survival, 5-year survival. Stage 2, 75%, stage 3, 50%, and stage 4, less than 5% is the 5-year survival. So now coming to the rectal cancer. So any doubts in colon cancer?
No, sir.
Am I audible? Hello, am I audible now? Yeah, fine. I'll share the screen. Actually, what happens is the device disconnects automatically every 1 hour. So every 1 hour, I have to reconnect it. Okay, so I have reconnected again. I'm sharing the screen now. Neha, can you share? Vipin, can you make me the host?
Yeah, I am making you the host.
Yeah. Fine. So I'll go ahead with rectal cancer now. So can I proceed? Fine.
Yes,
Guys,
sir.
can I proceed? Yeah, fine. Okay. So rectal cancer, definitely the treatment of rectal cancer differs from a colon cancer because the most of the rectum is confined within the pelvis. So surgical technically as well as the management in terms of the oncological clearance differs from a rectal cancer. And the most important difference in rectal cancer is you need to do a proper preoperative staging by imaging. So that preoperative staging for rectal cancer is done by rectal MRI. MRI is the investigation for staging a rectal cancer. So whereas in a colon cancer, you can easily stage it by a CT, abdomen, and pelvis. Rectal cancer, you must do a rectal MRI for accurate staging of the rectal cancer to know whether it's T1, T2, T3, or T4. So why do you do why do you need to do this staging by MRI? So I'll show the next slide. So this is the slide. Which explains about the rectal cancer MRI report. So basically, it clearly gives at what level the tumor is. So basically, the rectal MRI report gives whether the tumor is in the low rectum, mid rectum, or high rectum. So how does it give? Based on the distance from the how much the tumor, how much the distance is from the anorectal junction to the lower border of tumor. So if it is 0 to 5 centimeter, it is low. If it is 5 to 10 centimeter, it is mid rectum. If it is 10 to 15 centimeter and high, it is high rectum. So the most important is the T stage, which is being given by the MRI imaging. So how does it give the T stage? As I said before, the AJCC 8th division, T1 means the tumor is confined to the, see this picture, T1, the tumor is confined to the to the submucosa. Fine. So T2, so this gray line is the muscularis. Okay, so T2, the tumor goes into the muscularis propria, but it doesn't penetrate the muscularis propria. That is T2. T3 is a tumor which penetrates the muscularis propria and goes into the mesorectum. And this black line is the MRF. What is MRF? MRF is one important structure which you must appreciate in the MRI rectum to correctly delineate the T stage plus correctly delineate the circumferential dissection margin, which is the most important margin which you have to achieve in the surgery for rectal cancers. Fine. So this is the mesorectal fascia. So what happens is, so again I'll revise. T1 is a tumor which has infiltrated the submucosa. T2 is a tumor which is infiltrated this line is the muscularis propria, this line. Okay. So T2 is a tumor which has infiltrated the muscularis propria. And T3, which has infiltrated the muscularis propria and come into the mesorectum. T3 is further again divided into A, B, C, D. T3A is less than 1 mm, T3B is 1 to 5 mm, T3C is 5 to 15 mm, and T3D is more than 15 mm. So this basically depends upon how much extent it has come into the mesorectum. That is, if it has come to 2 mm, it is T3B. If it has come to 7 mm, it is T3C. If it has come to 18 mm, it is T3D. So this is based upon the distance. So what is T4A? T4A means basically it penetrates the peritoneum. So this applies only for the tumor, the part of the rectum which has peritoneum, which is the upper rectum. So what is T4B? T4B involves the adjacent organs. So this is the most important thing which is being given in the MRI of the rectum. So what does it give? First, it gives the location, whether it is low, mid, or high. Second, it gives the T stage. And in the T stage, the most important structure is the MRF. Why do we need the MRF? Because the involvement of this MRF, because when we are resecting the rectum, our surgical plane is just outside this mesorectal fascia. Therefore, the involvement of, if the MRF is involved, when you're doing a surgery, definitely your CRM is going to be compromised. So when do you say the CRM is positive? When the mesorectal fascia involvement is less than 1 mm. That is the distance between the mesorectal fascia and the tumor. If it is less than 1 mm, we say that it is T3 MRF positive. So this example, this what is given here is T3 mesorectal fascia positive. That is the tumor as reaching almost till the level of mesorectal fascia. That and the distance between the tumor and mesorectal fascia is less than 1 mm. So ideally, we need the distance between the tumor and the MRF at least more than 2 millimeter to say that the MRF is not involved. If it is less than 1 mm, we call it as an involved MRF or involved CRM. 1 to 2 mm, we call it as a threatened CRM, and more than 2 mm, we call it as CRM negative. You understood this concept? Can I repeat it?
Yes, sir.
Yeah.
Yes.
So in MRI rectum, see this all this MRI for rectal cancer has been well validated by two very famous trials, which is called Mercury trial. Mercury 1 trial has confirmed that MRI accurately predicts the T stage of rectum, and Mercury 2 again has increased. It has again proved that the MRI rectal staging is most important for a low rectal cancer staging. And what you must know in the MRI rectal cancer staging is the depth of penetration of the tumor, and based on which you guide the treatment for a particular rectal cancer. So you must know the what are the important things you might get from the MRI report. One is the location of the tumor, that is the level of the tumor, whether it is low rectum, mid rectum, high rectum. So high rectum and mid rectum is a cakewalk for the surgeon, because the sphincter complex is not involved, so you're going to easily get able to achieve a margin. Whereas a low rectum is definitely, it's going to be difficult to do the dissection in the deeper pelvis and to give an adequate margin. The next important thing is the T stage. So the MRI T stage is basically the T1. I told it's linked to the submucosa. So these are all will be clearly seen in the MRI image. So this is a pictorial representation of the MRI T stage. So T2 is basically the tumor is infiltrating the muscularis propria and not completely invaded the muscularis propria. So T3 is a tumor which has invaded the muscularis propria and come to the mesorectum. But the most important thing is T3 is again further divided into 4 stages, T3A, B, C, and D, based upon the distance which has entered into the mesorectum. So less than 1 mm, 1 to 5 mm is B, 5 to 15 mm is C, more than 15 mm is D. And so when do you say a CRM? So what is CRM? CRM is basically this mesorectal fascia. So why circumferential resection margin? So when you are doing the rectal cancer surgery, your plane of dissection will be just outside this mesorectal fascia. Therefore, if the tumor is close to this mesorectal fascia, your CRM is definitely will be high likely it will be positive. So as much as possible, you are going to assess this MRF, the distance of the tumor from the mesorectal fascia. So ideally, we want the distance of the tumor from the mesorectal fascia should be more than 2 mm. If it is less than 1 mm, like in this case, see this, the tumor is almost extending till the mesorectal fascia. So less than 1 mm means we call it as CRM positive. 1 to 2 mm, less than 1 mm, we call CRM positive. 1 to 2 mm, we call it as a threatened CRM. We call it as a threatened CRM. CRM is circumferential resection margin. More than 2 mm, we call it as CRM negative. Fine. So this is what. So remember, there are two things. The T3 stage is basically how much the tumor is protruding into the mesorectum. So it's basically the distance which has come into the mesorectum. Whereas the CRM, when you calculate, it's basically the distance between the tumor and the mesorectal fascia. You understood this? You understood the CRM concept?
Yes,
Yes,
sir.
sir.
Yeah, fine. So like in this picture, which is shown, the tumor distance between the distance between the tumor and the MRF is hardly nothing is there. It's less than 1 mm, and it is definitely MRF positive. MRF positive means mesorectal fascia involved. That means CRM is involved, because CRM is basically the mesorectal fascia. Because the surgical plane will be in this plane. We'll be dissecting along this plane. Fine. So ideally, there should be the tumor should be like this. Tumor should be like this. And the distance from this tumor till this mesorectal fascia should be greater than 2 mm. That's what I mean by what is circumferential resection margin. You understood now? Fine, guys. Can I go ahead?
Yes, sir.
Yeah. So the CRM is very important in rectal cancer. That's why I'm telling you very easily. So this is as the nutshell. So remember, even if you have not understood that picture, try to understand. If not, you remember this: the tumor reaching less than 1 mm of mesorectal fascia, like in this diagram, this one is CRM positive. Okay. Threatened, as I said before, if it is 1 to 2 mm means it is threatened. CRM negative means like this lesion. It is more than 2 mm. It is CRM negative. So this is the definition, important definition, which you must remember. Fine. So this is how the staging of MRI rectal cancer is an important thing, and any patient with rectal cancer, along with the routine workup, the most important investigation you do for the local staging of the rectal cancer is the MRI. Okay. And what you look on the MRI is, along with the most important thing which you have to do, look at a lot of things, like you have to look at the lymph nodes. You have to look out EMVI, extramural vascular invasion. That means basically the tumor will extend into the vessels, which is seen as EMVI. So, but need not remember all these things. You at least remember that the T stage is the most important thing which you get from the rectal cancer MRI, based on which you guide your therapy. Fine. So along with the T stage and an N stage, which you get from the MRI, so you basically start the patient on neoadjuvant therapy, depending upon whether it is a locally advanced. So if it's a locally advanced, you start the patient on neoadjuvant therapy. What neoadjuvant therapy? There's a lot of studies. There's a lot of advancement in this neoadjuvant therapy for rectal cancer, and I mean, you can take a separate class for this. But in short, you can give in the form of a short course RT, and you do surgery in a week. So basically, short course RT means you give 25 gray in 5 days. You give 2 days gap, 1 week gap, and then you do surgery for them. So this is short course RT. So what the next form of neoadjuvant therapy is to give a short course RT, but you don't do surgery immediately. So what they found was a famous trial. It's better to remember this trial. It is called the Stockholm 3 trial. So based on Stockholm 3 trial, what they did, they had 3 arms, and they found that the short course RT, you give a patient a rectal cancer short course RT, you give a gap of 6 weeks, 6 to 8 weeks, instead of the usual 1 week which you give for short course RT. They found that the pathological complete response is much, much better when you delay the surgery after short course RT. So therefore, neoadjuvant therapy can be given in this form also. The other thing is the usual long course chemo RT. Long course chemo RT, you give 50.4 gray. 50.4 gray in divided fractions of 1.8 gray. Okay. So over a period of 25 days, you give this long course chemotherapy, and then you give a gap of, again, for long course chemotherapy, I have to give a gap of again 6 weeks and then do surgery. So there are various types of neoadjuvant therapy, and recently the other advancement are like total neoadjuvant therapy, TNT. What is the TNT concept? You do everything before the surgery. What they found was the chemotherapy, if you give after surgery, the time taken for the patient to get the chemotherapy is very much prolonged. It almost, after the diagnosis of the tumor and to start the chemotherapy, it almost takes 4 months. So what you do, you first give a local RT to tackle the tumor, and then immediately after the RT, you give a chemotherapy to tackle the systemic disease, and then you do the surgery, surgery. So this is what is the concept of total neoadjuvant therapy. You give everything before the surgery. So this another emerging concept in rectal cancer treatment, and the results of the trial, which has investigated this, is called Rapido trial, which is also out, and they found that TNT is better in terms of managing rectal cancer. So there are a lot of things, but what is given in textbooks still now is the short course RT and long course chemotherapy. Both can be given. So always remember, if the tumor is bulky, and if you want the tumor to shrink in size, in that case you definitely have, or in other words, if the tumor is bulky and you want to downstage the tumor, in that case you definitely have to give a long course chemotherapy. You understood? For a bulky tumor, you want to shrink, you want to downstage, and you want to preserve the sphincter, and all these things you have to do a long course chemotherapy. So when you prefer a short course RT, in a nutshell, when you want to sterilize the margin, when your CRM is threatened, the tumor is just close to your CRM or the resection margin. So in that case, you can do a short course RT. So this, in a nutshell, this is where you choose a short course RT, and this is where you choose a long course RT. So for a tumor which is T4 with a bulky nodes, you definitely have to go for a long course chemotherapy. For a tumor which is very close to the circumferential resection margin, otherwise not a very bulky tumor, you better can go for a short course RT. And as I said before, short course RT surgery in a week is different from a short course RT followed by delayed surgery, as proven by Stockholm 3 trial. Also remember, there is another emerging concept of total neoadjuvant therapy, in which everything is given before the surgery, and it's being addressed by Rapido trial. So what are the surgeries for rectal cancer? Number one, anterior resection. Anterior resection you might have all seen during a general surgical training. Basically, the definition is the rectum is resected above the peritoneal reflection. Low anterior resection resected below the peritoneal reflection. Ultra low anterior resection, basically the rectum is very close to the sphincter complex, and you basically do an anastomosis at the level of the pelvic floor. That is why it is called as ultra low anterior resection. APR is basically you remove for the tumor which involves the external sphincter. Even if the tumor involves the internal sphincter, you can preserve the sphincter. But if the tumor involves the external sphincter, you can't preserve the sphincter. Then in that case, you must do a abdominoperineal resection for a tumor involving external sphincter. Okay. ELAP is another modification of APR, which is called as extra elevator abdominoperineal resection for a tumor which infiltrates the elevator ani. You get, I'll show you in a picture in the subsequent slides. Right. So this is what the concept of ultra low anterior resection. As I said before, this is called as a Rulius classification for intersphincteric resection. So what is this Rulius classification? There are 4 types in Rulius. So type 1, type 2, type 3, type 4. So just see this picture. First, I'll explain this thing. So this one is a circular muscle coat of the rectum. And you all know the circular muscle coat of rectum continues downwards. And here at the level of anorectal ring, the circular muscle coat of the rectum becomes the internal sphincter. Okay. At the same time, what is outside here? This is the external sphincter. And external sphincter continues and joins the levator muscle. Fine. And this line is your usual dentate line. And this is the anorectal. This is the region of the anorectal ring. Fine. So for a surgical reason, we consider the anorectal ring to the anal verge is the anal canal. So what we have is whatever we see, the distance of the tumor and the anorectal ring. So this anorectal ring we see, if the distance of that is more than 1 centimeter. So ideally, for a clearance of a tumor, I told about initially CRM. CRM, I told what should be the CRM. So what should be the DRM? DRM means distal resection margin, how much it should be. For a rectal cancer, if it is T1, T2, 1 centimeter is enough. For T3, T4, 2 centimeter is enough. These are ideal, but you cannot get a 2 centimeter margin for a tumor which is almost very close to the sphincter complex without compromising the sphincter. In that case, even for tumors which are close to the sphincter, a distal resection margin of less than 1 centimeter is permissible, but you should make sure intraoperatively that you do a frozen section and the margins are negative. Fine. So less than 1 centimeter margin is acceptable, but you have to make sure intraoperatively that the margins are negative by a frozen section. But ideally, what the studies say is for T1, T2, distal section margin 1 centimeter is enough. For T3, T4, 2 centimeter is enough. But for a tumor which is close to the sphincter complex, you can't give 2 centimeter. If you give 2 centimeter margin, it'll compromise the sphincter. So even if it is a less than 1 centimeter margin, a tumor-free margin is enough, but you have to document that the margin is tumor-free by intrafrozen section. So let's come to this Rulius classification. So type 1 is supraanal. Supraanal means the distance between this tumor and this anorectal ring. Anorectal ring, we marks the beginning of the sphincter complex. It's more than 1 centimeter. So in that case, you can comfortably give a 1 centimeter margin and resect the tumor. So this is type 1 supraanal rule here. So type 2 is less than 1 centimeter. So type 2, so the distance between this and this is less than 1 centimeter. So in that case, what you do, you take your resection plane, and what you do, you resect a part of the internal sphincter also here. So and then you take off like this. So this is called as partial intersphincteric resection. So what is type 3 intraanal? The tumor is involving the anorectal ring. So it is involving the internal sphincter. So in that case, what you should do, here the tumor is less than 1 centimeter from the anal rectal ring. Here the tumor is involving the anorectal ring and the internal sphincter. As I said before, if the tumor is involving the internal sphincter, you can try to do a sphincter saving surgery. But if the tumor is involving the external sphincter, you can't do a sphincter saving surgery. Fine. So if the tumor involves the internal sphincter, what you do, you have to completely take off the internal sphincter like this and take it off and leave only the external sphincter. So this is type 3. And type 4 is a tumor which involves the external sphincter. In this case, you can't preserve the sphincter, and these patients should mostly go ahead with the ELAP or a abdominoperineal dissection. So these are the 4 important types, and this classification is given by Rulius. So I hope I made the concept of intersphincteric resection to you clear, and I also made the concept of CRM and DRM in rectal cancer. Fine. Did you get the CRM and DRM concept in rectal cancer?
Yes, sir.
Yeah, fine. And the Rulier's classification?
Yes, sir.
Fine, very good. So Rulier's type 1, no issues. You can definitely give a margin and take off. Rulier's type 2, which is just
CRM
that's
and DRM.
yeah. What do you want?
One
Hello?
small space.
Yeah, the CRM. So
Yeah.
DRM is basically, suppose the tumor is here, always you give a margin and resect in whichever area it is. So, for example, if the tumor is in the transverse colon or in the ascending colon, you give a nice liberal 5 centimeter to 10 centimeter margin and resect it. And you are very comfortable and giving that margin and performing anastomosis. Whereas in rectum, you can't give that much margin because it's almost close to the sphincter complex. If you give that much amount of margin, you're going to compromise the sphincter complex, which is definitely going to affect the functional, the quality of life of the patient. So in this condition, what you do for rectal cancer, what studies have shown is for a T1 and T2 lesion, it's enough if you give 1 centimeter margin. For T3, T4, it's enough if you give 2 centimeter margin. But if the tumor is very close to sphincter complex, even if you are able to give a less than 1 centimeter margin is okay, unless you prove it intraoperatively that the margin is negative by a frozen section. That is what the distal resection margin in a rectal cancer. CRM is, as I said before, is basically a circumferential resection margin. So that is basically guided by your rectal MRI staging. And when you are doing I'll tell you about the CRM. It's basically you enter CRM when you're doing a total mesorectal excision. Fine. So this TME is basically the total mesorectal excision. Like what I said in colon cancer, it is central mesocolic excision with central vascular ligation. For rectal cancer, it's always an anti-resection along with a TME. So for a tumor which is in the upper rectum, you can remove the mesorectum 5 centimeter distal to the lower border of the tumor. That is enough. That is partial TME. So partial TME you can do for a high rectal tumor. But for a tumor which is present in the mid rectum or a low rectum, you have to do the entire TME, total mesorectal excision. So what is a total mesorectal excision? So basically mesorectum is the part like a mesocolon, which is present between the presacral fascia and the fascia propria of the rectum. You go in between this plane and remove the entire mesorectum without compromising the mesorectal fascia. If you breach the mesorectal fascia, you will come into this fatty mesorectal layer, and it might result in tumor spillage. So this CRM is what you achieve by doing a proper total mesorectal excision in the plane between the presacral fascia and in the plane between the presacral fascia and the fascia propria of the rectum. Fine. So fine. So this is all about I have an rectal cancer. You have any doubt on rectal cancer? I have given a very broad overview about the management of rectal cancer. I didn't go very deep. Fine. Any doubt you have?
So, want to ask you in a previous slide, what's the difference you told between the Mercury trial 1 and 2?
Mercury trial 1 and 2. So Mercury trial 1 and 2. Okay, I'll put a separate. I'll send you this papers Mercury trial. So basically, Mercury trial 1 was published a long back around 2006, I think, and then the Mercury trial 2 was then followed by Mercury trial 1. Just proved that MRI is accurate in predicting the T stage of rectal cancer, and Mercury trial 2 confirmed its importance with the how it affects the management of a low rectal cancer. I'll share you those papers. Okay. Fine. Any other questions?
Okay. And sir, in the Stockholm 3 trial, the duration of the delayed surgery is 6 weeks, no?
The delayed surgery is 6 to 8 weeks. 6 weeks.
Okay, okay.
The more delayed the surgery is, the better is this. Better is the response. Better is the response of the tumor.
Okay.
Stockholm 3 trial. Yeah. Anything? Let's go to the next question. Fine. Identify the false statement regarding the treatment of anal canal squamous cell carcinoma. Fine. So anal canal, the most of the benign condition of anal canal you would have routinely encountered during a practice. So I thought I need not cover about fistula, and hemorrhoids. So one important part in anal canal is just anal canal squamous cell carcinoma. So identify the false statement. The current protocol includes infusional 5-fluorouracil with the mitomycin C and external beam radiation to the pelvis with a dose of 45 gray. True or false? This is basically the Negro regimen. Okay, what Negro initially said was to give a dose of 30 gray, but afterwards it was modified. We follow the modified Negro regimen, which we give a minimum dose of around 45 gray to the not only to the anal canal cancer to the pelvis, but also it covers the regional lymph nodes. Most importantly, it should cover the inguinal lymph nodes. Okay, so that is true statement. So the point B, the inguinal nodes, pelvis, anus, and perineum should be included in the radiation fields. True or false?
True.
Yes, true, wonderful. So the point you should remember is the inguinal nodes is a regional node for anal canal carcinoma. For that's the point which, and that's therefore it should be included in the radiation field. Okay, and points option C, node positive disease are usually treated with an additional 9 to 14 gray for a total dose of 54 to 59 gray. True or false? See, the normal dose is 45 gray for in Negro regimen. If the patient is having a node positive disease, you have to give additional 9 to 14 gray. So that is true. The last point, only 2% of patients will have recurrence or fail to respond with Negro regimen. True or false?
False.
False. So it's almost 1/3 of patients will have recurrence with the Negro regimen, and such patients will need a salvage APR. Okay, it's 15 to 30% who will need recurrence or fail to respond with Negro regimen. Just give me 30 seconds, I'll come back. Fine, let's continue. Okay, so 15 to 30% will have recurrence or fail to respond with Negro regimen. So anal canal squamous carcinoma, chemo RT is the treatment of choice, and we follow the modified Negro regimen, which we give 45 gray of chemotherapy along with the mitomycin and infusional 5-fluorouracil. And inguinal node should be covered. And if you have a node positive disease, you give an additional 9 to 14 gray. So that comes to 54 to 59 gray. And 15 to 30%, that is 1/3 of the patient will have a recurrence or fail to respond. In such patients, you have to do a salvage APR. Okay, so let's brush up the other important aspects of the thing. Let me revise the anatomy first, which is given in subsystem. So as the picture is, I'll go fast. Anywhere you want to stop, I'll stop. I'll stress on the important aspects. So as far as the length of each part of the colon and rectum is given in subsystem, the cecum has a diameter of 7.5 centimeter. The length is 10 centimeter. The diameter of cecum is important because when there is a colonic pseudo obstruction, the cecum may get dilated. And when the cecum dilatation is more than 12 centimeter, which is assessed on an abdominal X-ray, in that case, you might have to do something even for a pseudo obstruction in the form of a decompression procedure. So more than 12 centimeter, there is a high chance of cecal necrosis and cecal perforation. And the 12 centimeter is a cutoff for the cecal dilatation, in which you have to think or contemplate for a decompressive procedure. So ascending colon is 15 centimeter, transverse is 50, descending is 25, and the sigmoid is 40 to 45 centimeter. So the maximum caliber is present in cecum is 1.5 centimeter. Remember the 12 centimeter cutoff for intervention if the cecum dilates, because that's a high risk for cecal necrosis and perforation. Sigmoid colon has a narrow diameter, which is around 2.5 centimeter. Always remember the colon has three tinea, the tinea mesocolica, tinea omontalis, and tinea libera. And the tinea is prominent in the transverse colon, and that is why the transverse colon has this triangular configuration in colonoscopy. Again, the terminal ileum joins into the cecum, and there is an ileocecal wall present in it, and below it there is an appendiceal orifice. And this picture shows the three tinea coli, And you also can see the appendices epiploidy, which is basically stalks of fat enveloped by peritoneum, and which is more pronouncedly present in the sigmoid colon, the tinea coli. And also remember, all these blood vessels which pierce the colon, they pierce on the mesenteric aspect of the tinea coli. So all these blood vessels, they pierce on the mesenteric aspect of the tinea coli, and that is why diverticulosis is more common on the mesenteric side of the side of the tinea coli. Fine, where the blood vessels perforate the bowel wall, there is a point of weakness in which the mucosa prolapses out and forms the diverticulosis. So this is sigmoid colon. Sigmoid colon, as I said before, it has a length of 40 to 45 centimeter, and important is it has a V-shaped mesentery. The apex of the V points to the iliac vessel. Okay. So the blood supply is very important, and I want to spend some time on this. The blood supply is basically is supplied by both by the SMA as well as the IMA. So let's concentrate first on the SMA branches. So this is the SMA. So the SMA first gives the middle colic artery, which divides into a right branch and a left branch. Then following which it gives a right colic artery. The right colic artery is not a constant branch. It is absent in many of the individuals. And then the SMA continues as the ileocolic artery, which further divides into the appendiceal artery and anterior cecal artery and the posterior cecal artery. Fine. So the SMA originates approximately at the level of around L1 on the inferior border of the pancreas and gives this middle colic, right colic, ileocolic. And then the IMA, it originates around or at L3 above the aortic bifurcation. It gives a left colic artery, which has an ascending and descending branch, sigmoid branch, and finally IMA continues as the superior rectal artery. Apart from this, the rectum also has a middle rectal artery, which is a branch of the internal iliac artery, and an inferior rectal artery, which is a branch of internal pudendal branch of the internal iliac artery. Fine. So the blood supply of rectum is robust. So there is no question of ischemia to the rectum, but the blood supply of a colon is not a colon is prone for ischemia, especially the left side of the colon is prone for ischemia at these 2 points. This point, the splenic flexure, is called as G, Griffith's point, and the rectosigmoid junction is called Sudak's point. Yes. So G comes first, therefore splenic flexure, Griffith's point, and this S is Sudak's point, which is at the rectosigmoid area. These are watershed areas which are more prone for colonic ischemia and in low force states. So remember, ileocolic artery is the most constant artery. The right colic artery anatomy is variable, as I said before, and it is absent in 18%. And Subiston, the exact percentage is given as 2 to 18%. Shackelford gives us 18%. Middle colic artery is absent in 20%. So almost in 20% of the region, both right colic and middle colic is absent. Subiston gives us 4 to 20%. Fine. In some patients, there is an accessory middle colic artery, which is present in 10% of the people. Fine. As I said before, the middle rectal artery is a very inconstant branch. It is absent in 40 to 80% of the specimens. Okay. So after talking about the vascular supply of the rectum, I should tell about this high ligation versus low ligation. What is the difference? So basically, high ligation means you ligate the IMA for rectal cancer surgery. You ligate the IMA either before or after giving of left colic artery. So this is a high. This picture is a high ligation. So here you can see the IMA is ligated above the takeoff of the. This is the left colic. So this is the IMA. IMA. This comes and gives the left colic, and then it continues as the inferior rectal artery. So what happens? You ligate the IMA at the origin. This is high ligation. Here, what you do after the left colic is given, you ligate the IMA. So what is the difference between high ligation versus low ligation? It doesn't have much difference. But oncologically, if you say, if you have an obvious node sitting on the at the origin of the IMA, it's definitely you have to go for a high IMA ligation and remove of this node. What is the drawback of doing this high ligation? You might injure the sympathetic plexus or the pre-aortic plexus, which is present in this area, thereby resulting in sympathetic denervation causing genitourinary complication. So if the patient doesn't have an obvious node, and if the patient you're planning to do a resection which doesn't involve a very low anastomosis, you can very well go ahead and do a low ligation. When do you prefer a high ligation? If you want to do an anastomosis at the very low in the pelvis, or if you have an obvious node in the IMA area, in such cases it's preferred to do a high ligation. You understood this concept of high ligation versus low ligation? Understood? Can I go ahead?
Yes,
Yes,
sir.
sir.
Fine. Good. So identify the false statement in rectal cancer surgery. High ligation involves ligation of IMA at the point of takeoff from the aorta. Low ligation involves true or false?
True.
True, obviously. High ligation, I told no. So high ligation, basically you like it here. Exactly where the IMA is taken off from the aorta. Okay. Low ligation involves ligation distal to left colic artery.
True.
That is also true. High ligation gives poor and lymph node yield. True or false?
False.
Yeah, high ligation
False.
definitely it gives higher lymph node yield when compared to low ligation. Hypogastric nerve damage and genitourinary complications are high with high ligation of IMA. True or false?
True.
True. Yeah.
True.
Yeah. So that's a false statement. So the collateral circulation for colon is very important. So always remember, as I said before, there are two important collateral circulation. One is the marginal artery of Drummond. So marginal artery of Drummond is basically all this the artery which runs along the margin of the colon, which collects which connects all the arterial arcades which supplies the colon. So so the one of the collateral circulation. So even if the right colic is blocked because of this marginal artery, it can supply the blocked the blocked area of the right colic through the ileocolic or through the middle colic. So marginal artery of Drummond is one collateral circulation. Also, I have marked specifically the ischemic the watershed area at the splenic pressure, which is the Griffiths point, and the rectosegment area is the Sodo's point, which is the watershed area, more prone for ischemia in patients with in case if there is a colonic ischemia. The other important thing is the arc of Raylan. Arc of Raylan is also called as meandering mesenteric artery, MMA. Meandering mesenteric artery. What does it do? It connects. So this one, no, I'll show you in picture. So this one. So this arc of Raylan is this artery which runs from the proximal IMA to the proximal SMA. In short, it's basically proximal SMA means it runs to the middle colic to the proximal IMA. So what happens even if IMA is blocked or if SMA is blocked, this arc of Raylan will be more well appreciated. It gets dilated and it serves as a collateral circulation. Fine. So these are the two important collateral circulation which is present in the colon. One is the arc of Raylan. I'm sorry, arc of Raylan, and the other is the marginal artery of Drummond. This is not able to come back. Fine. So venous drainage, it follows the arteries. The most important is all the right side of the colon till the transverse colon drains into the superior mesenteric vein and connects into the portal vein, whereas the left side of the colon and the rectum drains into the inferior mesenteric vein, which drains into the splenic vein. Always remember, like I told, high ligation of IMA is needed for anastomosis in the lower in the pelvis. The same thing, if you want to do a low anterior section or ultra low anterior section, you have to ligate the inferior mesenteric vein almost close to the origin. Okay, which is much appreciated if you assisted laparoscopic rectal surgeries. Fine. I'm sorry, some problem with this. My screen not able to change it. Fine. So lymphatic drainage, all this I have described before about epicolic group, paracolic, principal intermediate nodes, and rectum anatomy also I explained before. But I want to explain this facial layers again. Always remember this rectum. It has a peritoneal covering. In the upper rectum, peritoneum covers in the anterior and the lateral aspect. In the middle rectum, only in the anterior aspect. The lower rectum, no peritoneal covering at all. So that's point number one. The second point in the peritoneal covering important aspect is I appreciate these two fascias. The first fascia is this fascia. This is a presacral fascia. So with my highlighter is going along the presacral fascia down into the pelvis. The second highlighter now it goes along the fascia propria of the rectum. So first it went along the presacral fascia. Now it's going along the fascia propria of the rectum. So in between this presacral fascia and this fascia propria of the rectum is the plane in which you have to dissect for rectal cancer surgery to take the rectum along with the mesorectum. So you do a sharp dissection between the presacral fascia and the fascia propria of the rectum for a proper rectal cancer surgery. Fine. Also appreciate this one fascia which is called as rectosacral fascia, which starts from S4 and goes to the rectum. This is called Walde's fascia. So as you do a sharp dissection, you have to cut this Walde's fascia to reach the deep retrorectal pelvis. Fine. This Walde's fascia is basically it's a rectosacral fascia which starts from S4 vertebra and goes to the rectum. Also, anteriorly, the important fascia is the Denon-Villiers fascia. So Denon-Villiers fascia is basically the fascia which covering the prostrate and the seminal vesicles. So mostly we don't go in a plane anterior to the fascia, because if we go in the plane anterior to this Denon-Villiers fascia, we might injure the periprostatic plexus, which has the cavernosal nerve, thereby causing impotence. So most of the time we try to go behind this Denon-Villiers fascia so that we don't injure this periprostatic plexus and thereby doesn't cause any genitourinary complication. So remember this presacral fascia you should know, fascia propria of the rectum you know, the plane of rectal dissection is between these two fascias. Rectosacral fascia is basically a Walde's fascia, and Denon-Villiers fascia is the fascia covering the seminal vesicle and the prostrate. Fine. So the peritoneal reflection, this peritoneal reflection is present at 7 to 9 centimeter from anal verge in men and 5 to 7.5 centimeter in women. It's a point given in Sebastian. That's why I put this here. And as I said before, the peritoneal covering is present both on the anterior as well as the lateral aspects in the upper rectum. In the mid rectum, only in the anterior aspect. In the lower rectum is completely extraperitoneal in the deep pelvis. And regarding there is a three folds of folds called Houston's walls inside the rectum. That's called as a what Sabiston gives is these walls are present in the right, left, right. Whereas what Shackelford gives is these walls are present in left, right, left. Both are true, but there was a lot of confusion regarding this. What is right? But both the anatomy are present. But the one I just read on the literature, what it is given is the configuration which is given in Shackelford, which is left, right, left orientation, is the most common orientation of this Houston's wall. Okay, so when it comes for the exams, you have to read the other choices and judge whether it is taken from Shackelford or Sabiston, and accordingly you have to go for the right answer. Fine. Also, the other point which you remember is Sabiston give us right, left, right, and all these walls disappear on complete rectal mobilization. And remember, the complete rectal mobilization will give additional 5 centimeter length for the rectum. Fine. So these are all the Houston's walls configuration. So now come to the anal canal anatomy. I said before there are two things in anal canal anatomy which I want you to remember. I already stressed about the continuation of the muscular coat of the circular muscle of the rectum as the internal sphincter. This is the external sphincter which has three parts: subcutaneous part, superficial part, and the deep part, which is continuous with the levator ani. And we have an anatomical anal canal and a surgical anal canal. Surgical anal canal starts from this area, that is anorectal ring, to the anal verge. Anatomical anal canal starts from this area, that is a dentate line, to the anal verge. So that's the difference. Fine. So surgical anal canal, anatomical difference, you know. And this is easy question. I want to go to this nerve supply of the rectum. Fine. So as far as the nerve supply of the rectum, it comes from this sympathetic plexus which is present in the pre-aortic area. So these sympathetic plexus are nothing but preganglionic sympathetic fibers from L1, L2, and L3. Okay. So what is the sympathetic plexus? They come along the pre-aortic area and they form a superior hypogastric plexus, which again contains only sympathetic nerve fibers. And this superior hypogastric plexus, they condense and form two nerves, one right hypogastric nerve and one left hypogastric nerve. Right hypogastric nerve and left hypogastric nerve, that also contains only sympathetic fibers from L1 to L3. Okay, so right and left hypogastric sympathetic fibers. So what happens to the right and left hypogastric nerve? So this right and left hypogastric nerve, so this is the right hypogastric nerve, this is a left hypogastric nerve. So it receives fibers from S2, S3, S4. So these are S2, S3, S4. Sorry, this is S2, this is S3, this is S4. So it receives fibers from S2, S3, S4. What fibers it receives? Parasympathetic fibers from S2, S3, S4, and forms the inferior hypogastric plexus or the pelvic plexus. This is the inferior hypogastric plexus. Fine. So again, what is shown in the question mark is the pre-aortic plexus, which contains only sympathetic fibers. And what is shown in the question mark now is the left hypogastric nerve, basically, which contains only sympathetic fibers. The hypogastric nerve then receives the S2, S3, S4 parasympathetic nerve supply and forms the inferior hypogastric or pelvic plexus. And finally, you can see periprostatic plexus, which is present anterior to the Denon-Villiers fascia, which contains both a mixture of sympathetic and parasympathetic, the damage of which can result in impotence. So you're clear with this anatomy of sympathetic and parasympathetic nerves in the rectum, guys?
Yes, sir.
Yeah, fine. Someone has asked to repeat. I'll repeat fast. So basically, what you have to remember is you have to remember where does the sympathetic fibers come from, where does the parasympathetic fibers come from. Fine. So first, the nerve supply of the rectum, it starts from a, so you all know that sympathetic is a thoracolumbar outflow. Parasympathetic is a sacral outflow, craniosacral outflow. So sympathetic fibers come from L1, L2, L3. So this is the sympathetic fibers. These are all what are all present in this pre-aortic plexus with the sympathetic nerve fibers. Fine. So this area is all preganglionic sympathetic fibers from L1, L2, L3. And all this condense to form this part is a superior hypogastric plexus. Fine. My highlighter is in the exactly in the superior hypogastric plexus. Fine. So superior hypogastric plexus also contains only sympathetic fibers. Till now, it has not received any parasympathetic fibers. After that, what happens? The superior hypogastric plexus divides into a right hypogastric nerve and a left hypogastric nerve. It also till now has contains only sympathetic fibers. It has not received any parasympathetic fibers. So sympathetic fibers from L1, L2, L3 forms the superior hypogastric plexus, following which it formed the right and left hypogastric nerve, which all contain sympathetic nerve. After that, what happens? As I told before, this is the pre-aortic fibers. This is the superior hypogastric plexus. This is the right and left hypogastric nerve. What happens? Till now, it has only sympathetic fibers. Now, what happens? S2, S3, S4 has come. This will give fibers. S2, S3, S4 will give fibers. And this, along with the sympathetic fibers, join to form the inferior hypogastric plexus or the pelvic plexus, which contains both sympathetic and parasympathetic nerve fibers. From the pelvic plexus, it gives nerve supply to the bladder, to all the genitourinary organs. Fine. Are you clear now? Someone has asked. Can you tell me in which part you have a doubt or anything? Can I go ahead? Yeah, fine. So this is important because there's a lot of thing, but what I feel is if you remember what is given in these point in, sorry, I went somewhere, wait. If you remember these points which is given in Savastan as well as Shackelford, it's more than enough. So what happens in a high IMA ligation? So high IMA ligation means you ligate the IMA at this level. Wait, yeah, so you ligate the IMA at this level. So if you ligate IMA at this level, you can see my highlighter. You can see my highlighter, no? So high IMA ligation means,
yes.
So yeah, so when you ligate IMA close to the origin of the aorta, you can damage this sympathetic nerve fibers, the pre-aortic plexus. Thereby, what does it result? So these sympathetic nerves are important for, they're basically important for transfer of semen from the seminal vesicles to the prostatic urethra. So any defect in this sympathetic denervation will result in retrograde ejaculation and bladder dysfunction. Fine. So either the left or right hypogastric nerve must be preserved to maintain appropriate delivery of the semen from semen vesicles to the prostatic urethra. The sympathetic fibers, in other words, sympathetic fibers should be preserved for delivering the semen from seminal vesicles to the prostatic urethra. If any damage to the sympathetic nervous system happens, it results in retrograde ejaculation. So failure to preserve at least one of the hypogastric nerves during rectal dissection results in ejaculatory dysfunction. So even if one is preserved, there may not be any ejaculatory dysfunction. If both are damaged, definitely there will be ejaculatory dysfunction, which is retrograde ejaculation. So this is the problem which happens when there is damage to the sympathetic nerve fibers. What happens if there is injury to the mixed parasympathetic and sympathetic periprostatic plexus? Because it contains parasympathetic nerve fibers, and the parasympathetic nerve fibers are also called as nervi erigans, means the nerves which are responsible for the erection. And these patients with a damage to the mixed parasympathetic and sympathetic periprostatic plexus will have impotence and atonic bladder, and because of the impotence, they might have infertility. So that is important genitourinary complication. It's a very important slide which you must remember, given both in Sabiston and Shackelford. So sympathetic, in short, results in improper delivery of semen to the prostatic urethra, causing retrograde ejaculation. Parasympathetic nerve damage results in impotence. Fine. So this is AT zone. I've already discussed. Sphincter complex. So sphincter complex is formed by the internal sphincter, external sphincter, and anal cushions. So the resting tone, that is the normal tone of the sphincter in the resting state, 50 to 85% is given by the internal sphincter, 25% by the external sphincter, and even the anal cushions contribute to around 15% of the involuntary resting tone. Okay. So what is the nerve supply of the sphincter complex is another important thing. So internal anal sphincter is completely under involuntary control, basically autonomic control, where the sympathetic innervation is from L5 and parasympathetic innervation from nerve erigans. Whereas external anal sphincter is under voluntary control and it receives bilateral innervation through S2 and S3 and the terminal branch of S4. Fine. So internal anal sphincter, autonomic control, external sphincter is through the voluntary control by this sacral nerves. So regarding the physiology of the colon, I want to stress, just go through this MCQ. Identify the true statement regarding the physiology of colon. Colonic mucosa receives its nutrition from the bloodstream as well as lumen directly. True or false?
True.
It's false. It receives only from the lumen because the colonic mucosa doesn't receive from the bloodstream. It receives in the form of a butyrate, which is a short chain fatty acid, which is produced by the fermentation of fibers, dietary fibers, by the bacterial fermentation of the dietary fibers. Fine. So the short chain fatty acid butyrate is the main nutrition for the colonocytes. Fine. So that is a false statement. Short chain fatty acid acetate is the primary energy source for colonocytes. Come
False.
on, guys. False, definitely. So it's not acetate, it is butyrate. And how is butyrate produced? Butyrate is produced by bacterial fermentation on dietary fibers. Okay. Butyrate, the principal short chain fatty acid in the colon, is primarily absorbed and transferred to the liver, where it is primary substrate for cholesterol synthesis. True or false?
False.
It is false. Acetate is the one which
Which
is
acid?
involved in cholesterol synthesis, and butyrate is not taken to the liver for cholesterol synthesis. Lignin and psyllium are components of plants that are not fermented by human colonic flora and hence add to the stool bulk. True or false?
True.
So that is true. So these are the plant dietary fibers. They are not fermented. They just add the stool bulk. The other dietary fibers which are fermented by the bacteria gives butyrate, which is the main source of energy for colonocyte. So remember, the short chain fatty acid butyrate is the primary energy source for colonocytes. Fine. If you remember that, that would be good. So identify the true statement regarding this physiology of colon. In the colon, water is absorbed actively and sodium requires passive transport. True or false?
False.
False. Yeah, water is it's the other way actually. Water is passive, sodium is active. Bile acids are passively transported along the across the colonic epithelium by non-ionic diffusion.
False.
That is true. Fine. We'll see the other option. Colorectal diarrhea is seen as a transient phenomenon after extensive ileal resection. What is this colorectal diarrhea? Colorectal diarrhea means the presence of bile acids will exert an osmotic effect on the colon. So normally what happens, most of the bile acids gets reabsorbed in the terminal ileum and goes back to the liver. A little amount of bile acid escapes into the colon from the terminal ileum, and that what happens, it deconjugates and again it gets absorbed back into the circulation, completing the intrahepatic circulation. Sometimes when the terminal ileum is massively resected, the entire bile acid come into the colon and everything will be deconjugated and result in the formation of a secretory diarrhea. So that's what is called as colorectal diarrhea. Colorectal diarrhea means because of the presence of the bile acids, deconjugated bile acids in the colon, because of the disruption in the intrahepatic circulation, which happens after an extensive ileal resection. Fine. So it is seen as a transient phenomenon after extensive ileal resection. True or false? This point is
True.
given in substance. That's why I want to stress on it. So it is not it is false because it is definitely seen, but it's not a transient phenomenon. It's a permanent phenomenon. After right hemicolectomy, it will be a transient phenomenon because a hemicolectomy we remove only around hardly 10 centimeter of terminal ileum. So the most of the bile acids will get absorbed in the remaining part of the ileum in a few days. But in an extensive ileal resection, none of the bile acids are going to be reabsorbed. So therefore, it will be a permanent phenomenon after extensive ileal resection. Colorectal diarrhea will be a permanent phenomenon. Fine, it's not a transient phenomenon. Fine. The main source of nutrition for colonic epithelium is butyrate produced by the colonocytes. True or false?
False.
False. Not by
Why?
colonocytes, by bacterial flora.
Yeah, it's by the bacterial fermentation. Wonderful answer. Fine. So this is the right answer. Yeah, so the ball preparation before surgery, I don't want to stress on it. So always remember, ball preparation, there is still controversy whether to give or not. But if you give, the ideal solution is polyethylene glycol, PEGLUX solution. And some people prefer oral antibiotic also along with the PEGLUX. So oral antibiotic, what is usually preferred is neomycin erythromycin combination or ciprofloxacin metronidazole combination. Both can be used. And basically, giving this oral antibiotics, it reduces the risk of post-operative SSI. Right. So there's not much regarding bowel preparation. So it's still a controversy whether every patient needs. But what we usually do in routine clinical practice is patients who undergo a rectal surgery, definitely we give bowel preparation because we are very much worried about the anastomosis in the and anastomosis related leak which causing pelvic sepsis. Fine. So rectal prolapse, I'll brush up fast. What are the surgeries involved in rectal prolapse? There are two important options. You can either approach the prolapse transabdominally and perineally. And in a nutshell, always remember transabdominal surgeries have the best surgeries for rectal prolapse because they have the least recurrence rate. Fine. And what are the transabdominal option? It can be a Ripstein rectopexy. Ripstein rectopexy means basically the rectum is mobilized posteriorly and you keep a mesh in the posterior aspect of the rectum. You can also mobilize the rectum anteriorly and you can keep a mesh because they found that posteriorly, if you mobilize the rectum, there are high chance of the injury and there are high chance of constipation when you damage the pelvic nerves. Therefore, they modified it to form an anterior rectopexy in which only the anterior part of the rectum is mobilized and you keep a mesh. Resection rectopexy or Frickman-Goldberg procedure is the procedure when you have to do when the patient is having constipation as a significant complaint and the patient is having a redundant sigmoid colon. So redundant sigmoid colon and constipation as a significant in the history, you go ahead and do a resection rectopexy or Frickman-Goldberg procedure. Fine. These are the three transabdominal options. Transabdominal option is the best for rectal prolapse surgery because they have the least recurrence rate. What are the perineal option? Perineal operation, when compared to transabdominal, the recurrence rate is high. They are not very good. And what are the three options? Perineal proctosigmoidectomy. Basically, you remove the prolapsed rectum and the sigmoid colon and the redundant sigmoid colon by the perineal procedure. It is called the Altimere. The other procedure is called deloremy. Deloremy is basically an ideal procedure for a partial mucosal prolapse in which you just do a mucosal sleeve excision and a circular muscle plication. I'll show you in picture. TH procedure, which is usually done for patients who are completely unfit for anesthesia, involved in elderly, moribund patients who are bedridden. In such kind of patients, you do a TH procedure. So how it is done? So this MCQ will summarize most of the points. Yeah, fine. Someone has asked, well, yeah, Evelyn sponge, but we don't use Evelyn and all. We use mainly mesh. After the advent of mesh, we start keeping only mesh for all the rectal prolapse surgeries. Okay, identify the false statement regarding rectopexy. In patients with pre-existing constipation, a possible solution to the increased rate of constipation is performing a concurrent resection of the redundant portion of sigmoid colon. True or false?
True.
True, wonderful. Circumferential mobilization may decrease the rate of prolapse recurrence.
True.
Yeah. So circumferential mobilization, what they say is most of the time while doing rectal prolapse surgery, we try to do a circumferential mobilization. But the drawback of circumferential mobilization is though it decreases the rate of prolapse recurrence, it increases the rate of constipation. So there is a pro in it and there is a con in it, and you have to take it in a very dicey manner. Division of the anterolateral ligaments during circumferential mobilization increases constipation.
True.
True. The suture rectopexy has lower recurrence rate than mesh rectopexy. So that is a false statement. And the mesh rectopexy always have the lower recurrence rate. Right. So this is the recurrence rate. When compared to abdominal procedure, perineal procedure have a high recurrence rate. And of the perineal TH procedure, you can see which is done for elderly, moribund, bedridden patients have the highest recurrence rate. And among the recurrence rate, mesh rectopexy fares well in terms of recurrence. Fine. So last question on rectal prolapse. Identify the true statement regarding the surgery for rectal prolapse. Perineal procedure with resection have lower recurrence rate when compared to abdominal procedures. True or false? Perineal procedure with resection.
False.
False. Wonderful. Deloremy procedures involves perineal proctosigmoidectomy with colonial anastomosis. This is just to play with whether you know the name of the procedure and what is it actually.
False.
Yeah, perineal proctosigmoidectomy is basically Altimeus. Deloremy is basically a muscular application. Okay, I'll tell you what is. I'll show you a picture. TH procedure involves anorectal mucosectomy with muscular application.
False.
False. TH is basically a
False.
bedside procedure where you just put two incision and encircle the rectum, basically forming a support. TH procedure has the highest recurrence rate and used only for elderly patients with significant comorbidities.
True.
True. Fine. So this is the Alchemist procedure. Basically, you perineally you take out the rectum and the redundant sigmoid colon, and you put an incision beyond the dentate line. Completely resect the redundant sigmoid and the rectum, and you do a anastomosis. And this is the Delorme procedure. What you do, you don't do a complete excision. You don't do a full thickness excision. You do a partial excision, and then what you do, you do a plicating sutures, like what you do for a hydrocele, like a plicating sutures in the muscular coat of the rectum. Okay, so this is a Delorme procedure. Fine. So understand this term: Altimeus, Delorme, Ripstein, Frickman, Goldberg. They might play with these terms for your framing your questions. So Tej procedure is basically a bedside procedure where for elderly patients you do put two incision, you encircle the rectum with a mesh, so that it forms a mechanical support. High rate of recurrence. So next important aspect in the benign part of the rectum is a solitary rectal ulcer syndrome. First, we'll start with the MCQ for this. Identify the false statement regarding solitary rectal ulcer syndrome. It is always located in the anterior aspect of the rectum, 4 to 12 centimeters from the anal verge. True or false?
True.
It is true. Okay, so solitary rectal ulcer syndrome, it's located in the anterior aspect of the rectum, and the distance is mentioned in subexternus 4 to 12 centimeters from the anal verge. So remember, every point is important. It has been asked so many times in MCQs, SRUS. SRUS can be a crater-like ulcer with a central fibrinous depression or a polypoid lesion. True or false?
True.
That is also true. So always remember, though they say SRUS, solitary rectal ulcer syndrome. So what happens is it's called as triple lie. It's not always the solitary rectal ulcer. Triple lie. What is the triple lie here? It is not always solitary. It is not always found only in the rectum. It's also found in sigmoid. It is not always an ulcer because it can be like a polyp also. So it's a triple lie. The triple lie is one thing which they say for solitary rectal ulcer syndrome. So it can be an ulcer or a polypoid. So, but patients are typically young female with an average age of 25 years and a history of staining and difficult evacuation. True or false?
True.
Wonderful. So young female, 25 years is important thing you must remember. This also they ask. And it is exclusively associated with the internal intussusception and full thickness rectal prolapse. False. Wonderful. So always remember, SRUS doesn't mean that patients whoever have intussusception rectal prolapse will have SRUS. It has been postulated that rectal prolapse and intussusception is associated as one of the conditions, but it is not that all patients with rectal prolapse will have SRUS. Fine. It is not exclusively associated. Fine. So remember this. Again, another question on SRUS. Identify the false statement regarding SRUS. Common pathological findings includes the presence of mucus-filled glands misplaced in the submucosa and lined with normal colonic epithelium. True or false?
True.
Yeah, this is a very important pathological finding. It is called as colitis cystica profunda. What I mentioned in that statement is colitis cystica profunda. Basically, the submucosal layer, there will be a lot of mucus-filled glands when you do a biopsy from the solitary rectal ulcer. Fine. Full thickness rectal prolapse, internal prolapse, paradoxical fibrorectalis syndrome, and thickened rectal folds are common findings in SRUS.
True.
This is true. It is only thing is they are not exclusively associated with. Local excision is a treatment of choice for symptomatic SRUS. True or false? False. Wonderful.
False.
Because local excision, it will never heal solitary rectal syndrome. Always you should think of managing by whatever, if the patient is having an obvious predisposing cause, treated, or biofeedback and dietary modification. Unless the patient is not improving with these methods, and if you have a suspicion for malignancy, in that case we can go for a low anterior resection. That too, not an ulcer excision. SRUS in patients with mucosal prolapse should be managed with non-surgical methods.
True.
Yeah, true. In a patient with mucosal prolapse, you can manage with non-surgical methods. But in the patient with a complete rectal prolapse, you should, in such patients, the rectal prolapse surgery will have a role in the healing of solitary rectal ulcer syndrome. Fine. So this is a nutshell about, I have condensed about the important points about SRUS. So SRUS can be a crater-like ulcer with a fibrinous central depression, or it can be a polypoid lesion. As I said, it is a triple lie. It is not only an ulcer, it can be a polyp. It is always located on the anterior aspect of the rectum, 4 to 12 centimeters from the anal verge. That corresponds to the location of the fibrorectalis sling. It is frequently, although not exclusively, associated with internal intussusception or full thickness rectal collapse. Okay. And patients are typically young female with average age of 25 years with a history of staining and difficult evacuation. Pathological features I told before: colitis cystic profunda, the submucous has a lot of glands are there. Another important thing is there's a thick layer of fibrosis in the lamina propria and a central fibrinous exudate. This is another important pathological features. What is the etiology of SRUS? Because of the chronic ischemia. Some say because of the staining, because of the digital self-impaction, it may cause an SRUS. These are the dephocographic findings, not very important. These are commonly found. There is a rectal prolapse, internal prolapse, paradoxical puber rectalis, and thickened rectal folds. So it doesn't mean that if the patient has a prolapse, you should attribute the SRUS to the rectal prolapse as a causative factor. So what is the treatment? SRUS with full thickness rectal prolapse, if you do a prolapse repair, 80% there is chance of healing. But SRUS with only a mucosal prolapse, there is only 25% chance of the SRUS healing. Therefore, the prolapse repair is not recommended with SRUS only with the mucosal prolapse. So remember this point: SRUS with full thickness rectal prolapse repair has a role. Whereas SRUS with the mucosal prolapse only, prolapse repair doesn't have a role because the cure rate is only 25%. So what you do for SRUS with the internal prolapse or a pelvic muscle dysfunction, you just do dietary management or a pelvic biofeedback or a pelvic floor retraining, and sometimes a short-term use of anti-inflammatory agents. So only for patients with SRUS and full thickness rectal prolapse, the prolapse repair surgery is going to be of benefit. Other patients, you have to go for non-surgical methods for a management. Fine. Okay, this is about rectal prolapse. So I'll go fast on IBD. Can I have 15 more minutes? If you guys are not tired and I mean fresh enough to listen, I'll take 15 more minutes for finishing IBD. That is the last. What do you say?
Yes, sir.
Fine. Okay, if one yes comes, that's enough. Even if one is listening, fine. Okay, one more as somebody says. Okay, as much as I'll try to go fast. If you want me to go slow, I can also go slow. Whatever is your wish. Fine. So IBD. So yeah, I'll go as much as possible. I'll cover all the slides. So inflammatory bowel disease is another important aspect as far as the benign part of the colorectal condition is present. Mostly it is managed by the medical gastroenterologist, and we get patients only when they refer us for surgery. And it is not our domain. We don't see. I mean, I have not seen much cases of inflammatory bowel disease unless you have a very robust on the prolific medical gastroenterologist in your place of practice. You will be able to see a lot of cases. Otherwise, you will be see only a rare few cases. Another thing is this inflammatory bowel disease is mostly a Western disease, and that's another reason why we don't see much. But anyhow, this is a very important thing because it's the management of it is very important, and it's a very treatable condition. Especially ulcerative colitis is curable by surgical methods. So one thing, the first thing which I want to know is you should go through the table which is given in substance, which is the difference between ulcerative colitis and a Crohn's colitis. Okay, so they were nicely divided based on the gross appearance. Like for example, ulcerative colitis, it basically involves the partial thickeness. It involves only the mucosa and the submucosa. Therefore, whereas Crohn's, it's a transmural inflammation. Ulcerative colitis, inflammation happens only in the mucosa and the submucosa. Whereas Crohn's colitis, it is transmural. So because of this, in the gross feature, you have thickened wall, more commonly in Crohn's colitis. Thickened mesentery, more commonly in Crohn's colitis. Because it involves the serosa, all the momentum gets wrapped around it, causing serosal fat wrapping. And segmental disease is more common in Crohn's colitis. So what is segmental disease? In ulcerative colitis, basically the disease starts from the disease starts from the rectum, and it grows extends proximally in a continuous fashion to involve the remaining part of the colon. This is what happens in ulcerative colitis. So it starts from the rectum and grows in a continuous fashion. Whereas Crohn's colitis it's not the same. Rectum is not always involved in the Crohn's colitis, and most of the time it's a segmental distribution. It progresses in a discontinuous pattern. That is Crohn's colitis. Okay. Microscopic appearance, as I said before, in Crohn's colitis, it is transmural inflammation. Epithelioid granulomas and lymphoid aggregators are present in the Crohn's colitis. So Crohn's colitis looks like a TB, tuberculosis, in the histological picture in the form of a epithelioid granulomas. So again, microscopic appearance, I said before, clinical features. So bleeding per rectum, diarrhea, because ulcerative colitis involves the rectum first, and rectum is less commonly involved in Crohn's colitis. Bleeding per rectum is more common in ulcerative colitis when compared to Crohn's colitis. So diarrhea is almost equally common. Obstructive symptoms, it is more common in Crohn's. Why it's more common? Because Crohn's has transmural inflammation, because of which there are more prone for stricture formation. So stricture formation is very prominent finding in a Crohn's colitis. It's very common because of the transmural inflammation, and that's why obstructive symptoms are very commonly present there. Anal or perianal disease is very rare in ulcerative colitis, but is very common in Crohn's colitis. Okay, the risk for cancer also is high in Crohn's colitis when compared to ulcerative colitis. And small bowel disease, ulcerative colitis, you see, it doesn't involve only a few proportions. There might be involvement of small bowel in ulcerative colitis. If there's extensive disease from the rectum, it can go and spill over into the terminal ileum, and that is called as backwash ileitis. Backwash ileitis. That can happen in ulcerative colitis. So that can involve only the terminal ileum. Whereas small bowel disease, the Crohn's disease can affect any part of the gastrointestinal tract from the esophagus to the anus. And so small intestine also will be affected in a Crohn's disease. So coloscopic features, as I said before, it's a continuous involvement from the rectum and then goes proximally, whereas Crohn's is discontinuous. Rectal disease, friability, are very common in ulcerative colitis, whereas aphthous ulcer, deep longitudinal ulcers, cobblestoning appearance and pseudo cobblestoning appearance are common features present in ulcers are a common features present in Crohn's colitis. And remember, the cobblestoning appearance is a very typical feature of Crohn's colitis. Fine, so let's do this MCQ. Smoking has identify the true statement regarding IBD. Smoking has a protective effect on Crohn's disease, whereas in ulcerative colitis it increases the severity. True or false?
False.
False.
False, because it's the other way. Okay, I mean the smoking has a protective effect on ulcerative colitis. Okay, appendectomy decreases the risk for Crohn's disease.
False.
False.
Yeah, appendectomy is for ulcerative colitis and not Crohn's disease. HLA DR1501 allele is associated with a more virulent growth. True or false?
True.
No. This is given in this allele is given in Sabiston. That's why I took it this point. The 1501 allele is benign. 1502 allele is associated with a more virulent growth. Okay, so they're given only one line on it, so I thought it might be asked, so I just took it. So 1501 allele is benign. 1502 is virulent. Okay, so that is also false. The genetic predisposition for ulcerative colitis is not inherited in a classic Mendelian pattern, suggesting the influence of environmental factors on individual susceptibility. So that is a true statement. It is not only genetic; it is genetic along superimposed on the environmental factors and dietary factors play an important role in the causative factor for ulcerative colitis. Fine. The answer has been marked. So this is the gross difference between ulcerative colitis and Crohn's disease. As I said before, bowel wall, mucosa and submucosa in ulcerative colitis, transmural in Crohn's disease. The extent, as I said before, ulcerative colitis starts from the rectum. It extends proximally in continuous uninterrupted fashion. Whereas in Crohn's disease, it's a discontinuous manner. It's present in the colon. It can present in the small bowel and any part of the GIT. And skip lesions are very commonly found. Terminal ileum is not involved in ulcerative colitis, except in cases, like I said before, the backwash ileitis in extensive ulcerative colitis, some disease can spill over into the ileum. In such case, the ileum involvement, there will be a dilated ileum. Okay, unlike in Crohn's disease, if the ileum is involved, it's a contracted ileum. Whereas in ulcerative colitis, the ileum backwash ileitis will cause a dilated ileum. Okay. So the P ANCA is ulcerative colitis. The P ANCA is positive, is around 86% it is positive. Whereas in Crohn's disease is ASCA. So C for C. In Crohn's disease, ASCA is anti-Saccharomyces cerevisiae antibody is the thing which you find. Whereas in ulcerative colitis is the P ANCA. Fine. All this distal proctitis, urgency, rectal bleeding are all more common in ulcerative colitis. Since Crohn's disease is not very commonly affects the rectum, it is less common. And perianal disease is absent in ulcerative colitis and present in Crohn's disease. Fine. So I want to add one more point. So rectal sparing is present in how many percentage of Crohn's disease? That is, how many percentage of Crohn's disease doesn't involve the rectum? It is given in Sabiston, which is 40%. That means 40% of Crohn's disease do not involve the rectum. Whereas in ulcerative colitis, the disease starts from the rectum and goes proximally. Whereas Crohn's disease, 40% do not involve the rectum. Rectal sparing is 40%. Only 60% in Crohn's disease will have rectal involvement. Okay, that's the other way to interpret it. This is another important point. What do you suspect? As I said before, stricture formation is a very common finding in Crohn's disease because it has a transmural inflammation. Whereas this ulcerative colitis, it has a partial thickness inflammation involving the mucosa and submucosa. So, what is the significance of stricture formation in ulcerative colitis? Always you should think about malignancy, but it is not a very common thing, malignancy, but you should keep malignancy in mind when there is a stricture in a patient with ulcerative colitis. Okay, so let's do this MCQ. Identify the true statement regarding ulcerative colitis. Colonic stricture is a common finding in ulcerative colitis. True or false?
False.
It is false. It is not a common finding. Okay, it is common finding in Crohn's disease. Colonic stricture in ulcerative colitis is always malignant and needs dissection. True or false?
False.
False.
It is false. It is not always malignant, but you have to think it as malignant and work up the patient and manage accordingly. Most of the time, it might be just a benign lesion because of the hyperplasia of the muscularis propria layer due to the inflammation. Okay. Shorter the duration of the disease, more the chance of malignancy. True or false?
False.
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 Longer the duration of the disease, more the chance for malignancy. Colonic stricture occurring proximal to splenic pressure are mostly malignant. True or false? This is the true statement. Okay. So the stricture which is proximal to splenic pressure are most commonly malignant. Okay. So this is the important aspects. I just taken completely from Shackle Subsistent these points. These are the points you should remember. The colonic stricture is present in 5 to 12%. Most often, the cause of the colonic stricture in ulcerative colitis is because of the hypertrophy of the muscularis and a benign condition. So, but always you should exclude cancer in this condition when there is a stricture in a patient with ulcerative colitis. So, what are three important features associated with malignant stricture? One, appear later in the course of ulcerative colitis. That is, more the duration, more the chance of malignancy. Number two, as I said before, location proximal to the splenic fracture, 86% it is malignant. Okay. Large bowel obstruction caused by the stricture is most likely because of a malignant stricture. Fine. Next important point, which is asked in your exam, is the extraintestinal manifestation of ulcerative colitis. So the answer is already marked, but I will go to the statement fast. Identify the true statement regarding ulcerative colitis. Arthritis doesn't depend on the intestinal disease activity. So this is a false statement. There are some extraintestinal manifestation which depends on the intestinal activity, and there are some extraintestinal manifestation which doesn't depend on the intestinal activity. In other words, there are some extraintestinal manifestation like arthritis. If you do a colectomy, the arthritis will improve. The patient will be relieved of arthritis. Whereas some, even if you do colectomy, nothing will happen to the extraintestinal manifestation. So you should know what are those conditions. I'll brief about that in the next slide. The next option B, erythema nodosum typically is manifested on the pretibial region as an erythematous plaque that progresses into an ulcerated painful wound. True or false?
True.
No, it is false. It is not erythema nodosum. What I described is a pyoderma gangrenosum. It is not erythema nodosum. Fine. Colectomy has no effect on the course of primary sclerosing cholangitis. That is true. Okay. So even if the patient has primary sclerosing cholangitis, even if you do colectomy, there is nothing. The PSC won't be cured, so it doesn't have any effect on primary sclerosing cholangitis. Patients with primary sclerosing cholangitis and ulcerative colitis have a severe form of intestinal disease. True or false?
False.
Yeah, it is false. So remember, as far as PSC and ulcerative colitis is concerned, as far as the intestinal activity is concerned, they have a quiescent intestinal activity. That is, they have a very mild version of the disease as far as the colitis is concerned. But they have more chance of developing into a malignancy. That is number one. Number two, the PSC may not improve even after colectomy, and the patient might ultimately lead up in developing cholangitis, primary sclerosing cholangitis, resulting in leading to liver transplantation. The patient might need liver transplantation as a final treatment for this condition. So these are the extraintestinal manifestation to be, in short, I have condensed everything. The most common is arthritis, 20%, ankylosing spondylitis, which is more common in patients with HLA B27, 3 to 5%, erythema nodosum is 15%, pyoderma gangrenosum, and PSC it is 5 to 8%. And this is the most important point, which are the conditions which improves or resolves after colectomy. Remember, arthritis, angspon, erythema nodosum, pyoderma gangrenosum. Both the joint and skin condition, it improves after colectomy. But primary sclerosing cholangitis doesn't resolve after colectomy. I'm telling again, even if you do colectomy, primary sclerosing cholangitis is not going to improve. You might have to go ahead for a liver. I mean, the patient might end up in the future for liver transplantation. Also, the other point which you should remember as far as UC and primary sclerosing cholangitis is concerned is the colitis is very mild. The patient will have a very quiescent disease as far as the colon involvement is concerned, but they have higher chance of malignancy. At the same time, the primary sclerosing cholangitis may progress and the patient might ultimately need a liver transplantation. You understood this? It's not a manifestation. Any doubts in this?
Sir, doubt is there. The ankylosing spondylitis is not resolved after the colectomy, no, sir?
No, not
It is
resolved.
given in the substance.
Substance is given, improves or no, only the PSC doesn't resolve after colectomy. Angstpon resolves after colectomy. You're saying that substance given that angstpon doesn't resolve.
Okay, fine.
I'm not sure. I mean, someone has asked carcinoma more likely in ulcerative colitis or Crohn's, more likely in ulcerative colitis or Crohn's disease. I'm not sure about the exact statistics, but both has a risk of carcinoma, both ulcerative colitis and malignancy. Exact percentage, I don't know which is more. Okay, I'll confirm and tell. I'll take this as my. I'll refer the literature and exactly tell which is more common. I want to give you the exact part. Okay, I'll note down the question and I'll answer you in the group. Fine. Fine. Okay. So, but this I'm sure. I'm very sure that ankylosing spondylitis improves the results after colectomy, and only primary sclerosing cholangitis doesn't resolve after colectomy. Fine. And this is the part which I've taken completely from Subiston. I've taken all the points from Subiston which you have to remember as far as P is in ulcerative colitis. Number one, patients with ulcerative colitis who have this phenotype, HLA-B and HLA-D3, are more likely to develop PSC. That is number one. Number two, as I said before, PSC patient with ulcerative colitis, the intestinal disease is very quiescent, but the risk for colon cancer in this patient is 5 times greater. So that point I want to remember. And finally, disease is progressive. That is, the PSC is progressive and ultimately fatal unless liver transplantation is undertaken. There's a point given in. All these points are true, taken completely line by line from Savistton. Fine. So cryptapsis, basically all these neutrophils which is present in the mucosa and submucosa are called as cryptapsis. It's a characteristic feature. But cryptapsis is not specific for ulcerative colitis because it is also seen in Crohn's as well as infectious colitis. So now coming to the ulcerative colitis and malignancy, identify the true statement regarding ulcerative colitis. Carcinoma arising in ulcerative colitis are well differentiated and less aggressive. True or false? See, it's a carcinoma which is arising from a chronic inflammation state. So will it be well differentiated and less aggressive?
False, false.
False. Fine. Patients with disease confined to the left side of the colon have a lower risk of development for cancer than patients with disease involving the entire colon. So entire colon means pancolitis, left-sided colitis, which is more prone for developing cancer.
Pancolitis.
Pancolitis. So that is what. So that treatment is true. Recommend surveillance colonoscopy every 5 years, beginning 8 years after the onset of pancolitis. For a patient with pancolitis, you have to repeat colonoscopy every 1 to 2 years. Okay, not every 5 years. Okay. For left-sided colitis, you can do once in 5 years. For a pancolitis, every 1 to 2 years. More than 50% of patients with the low-grade dysplasia progress to invasive malignancy. True or false? That is also false. Low-grade dysplasia, only 10% will progress to invasive malignancy. Fine. So basically, if you do an ulcerative colitis colonoscopy, they take biopsy from multiple points, and the biopsy you have to look for any dysplasia. And this dysplasia can be a low-grade dysplasia, can be a high-grade dysplasia, and there is one more condition called DALM. What is this DALM? Dysplasia associated with a lesion or a mass. So low-grade dysplasia, only 10% risk of malignancy. High-grade dysplasia, 30% risk of malignancy. DALM has more than 50% risk of malignancy. So if a patient has high-grade dysplasia and a DALM, definitely he has to go for a surgery than when the patient who has a low-grade dysplasia. Fine. So that's what this thing is. So what is the risk factor for carcinoma? In a patient with ulcerative colitis, as I said before, it's a prolonged duration, pancolitis, continuously active disease, and the patient is having severe inflammation. What is surveillance colonoscopy? I said before, for pancolitis, every 1 to 2 years. For ulcerative colitis, 12 to 15 years after the onset of ulcerative colitis. And as I said before, for dysplasia, low grade, 10% risk, high grade, 30 to 40% risk of malignancy. For DALM, more than 50% risk of malignancy. Okay, it's all given in Sabiston. Fine. So identify the true statement regarding ulcerative colitis. In acute ulcerative colitis, a complete colonoscopy is essential to assess the severity of the disease and decide on appropriate treatment. True or false?
True.
It's false. In acute ulcerative colitis, you can't do a complete colonoscopy. What you have to do is you just do a sigmoidoscopy and confirm it is ulcerative colitis and start the patient on treatment. And once the acute ulcerative colitis is resolved, you can do a complete colonoscopy. Fine. So the point is, in acute ulcerative colitis, you should never do a complete colonoscopy. Fine, to assess the severity of the disease. Okay, rectal sparing happens in 40% of patients with Crohn's colitis. I said before this point. Yeah, so rectal sparing, that is a true statement. Okay, rectum is always involved in perianal Crohn's disease. True or false?
False.
False. Left sided colitis and prolonged duration of the disease increase the malignancy risk.
False.
False. It is pancolitis and prolonged duration of the disease increase the malignancy risk. Okay. So what is the management of the IED? In short, the broad concept is the management first, you do a scopy and grade the or an imaging. For ulcerative colitis, you can do a colonoscopy. For a Crohn's disease, small bowel involvement and all, you might have to do a MR enteroclysis or to assess the grade the activity of the disease. Once you grade the activity of the disease, you give an induction treatment, which is depending upon the severity, mild, moderate, and severe. You can give the induction treatment. And once a patient goes into remission after starting the induction treatment, you maintain the keep the patient on maintenance treatment. So till this point, it is all medical management, and the patient will come to us only at the final stage where the patient needs surgery because he is having either an acute severe inflammatory bowel disease or the patient is not able to tolerate the medications used for ulcerative colitis. So which of the following? So there is to assess the severity, we follow a criteria called True-Lowitz criteria for ulcerative colitis. Which of the following is not a component of True-Lowitz criteria? Frequency of defecation, bloody stool, tachycardia, hypertension. You guys have not heard of a True-Lowitz criteria?
No, sir.
So True-Lowitz criteria, see, the hypotension is not a part. I have condensed this is the True-Lowitz criteria. So these are the important things. So the first two, the frequency of defecation and bloody stool. So remember, any patient with ulcerative colitis, it's the frequent stools and bloody stool, which is the most common. Those two are a very important criteria. Apart from that, there are two clinical criteria, fever and tachycardia, and two laboratory criteria, anemia and ESR. So two clinical, fever and tachycardia, two laboratory criteria, anemia and ESR, plus the essential criteria, which is frequency of defecation and bloody stool. So based on the 6 criteria, we classify it as mild, moderate, and severe. So just see the severe ulcerative colitis. The patient will have more than 6 bloody stools, 6 stools, and the stools will be bloody. Patient will have fever, patient will have tachycardia, patient will have anemia, that is HB of 10 gram or less, and ESR is 30 mm or more. So these are the criteria for severe ulcerative colitis for a patient with ulcerative colitis based on True-Lowitz criteria. So this is the management of ulcerative colitis. For induction of remission for ulcerative colitis, you can use mesalamine, which is commonly available as Misacol. So we give oral Misacol. Sometimes in a mild patient, in a patient with a mild disease, you can also give oral budesonide. If the patient has a severe disease or a moderate ulcerative colitis, mesalamine and a topical steroid may not be effective. In such patients, you might have to give IV steroids or anti-TNF alpha in the form of infliximab, adalimumab, and golimumab. So just remember, for a mild disease, you can just manage with the mesalamine. For a severe disease, you might have to go for IV steroids or anti-TNF alpha agents. The same thing, this is the nutshell of medical therapy of ulcerative colitis. This is table given in Shackleton. For a mild disease, you can manage with oral misacol, that is 5-aminosalicylic acid is a misacol, or a rectal formulation also is available for the same. In a moderate disease, you can give oral prednisolone or a topical budesonide. In a severe disease, you can use IV steroids or infliximab. So mild disease, you can go ahead with you can get away with misacol, and for severe disease, you might have to use anti-TNF alpha. So basically, you stratify the risk of the patient. This is the management of Crohn's disease. In Crohn's disease, the same thing, you see whether the patient is having a low inflammatory burden or a high inflammatory burden based on his symptoms, based on his laboratory findings, based on his endoscopy findings, and see whether the patient is having a high risk, that is the age of diagnosis, previously had any stricturing or penetrating behavior. And if the patient is a low risk category, you can manage with a budesonide or prednisone. In Crohn's disease, see, remember, in Crohn's disease, mesocol doesn't play any role because mesocol acts mainly in the colon, doesn't act in the small bowel. So Crohn's disease, mesocol doesn't have any role. So in Crohn's disease, if it's low risk, you can give budesonide or prednisolone. But if it's a high risk patients in Crohn's disease, it's better to go for infliximab. Fine. So most of the time in Crohn's disease, the patient will need infliximab. Okay. So now coming to the indications of surgery in ulcerative colitis, the surgeon's role, emergency, if the patient is having acute severe ulcerative colitis, the criteria which I showed is Trulov and White's criteria, as I told before. Toxic megacolon, perforation, massive lower GI bleeding is not a common finding in ulcerative colitis, and large bowel obstruction. What are the elective indications? Steroid dependent or refractory disease, side effects of steroid therapy, patient who has high grade dysplasia or DALM or cancer, or non-compliant or cannot afford therapy. So these are some of the indications for which you have to do surgery for ulcerative colitis. And this is the flow chart for the management of ulcerative colitis for acute severe ulcerative colitis. So in acute severe ulcerative colitis, in which the patient is toxic, and as I said before, we follow the True-Love-Witz criteria. It is given here, True-Love-Witz criteria. So this is the flow chart which is followed, which will be helpful to you to remember for managing a patient clinically. So what you give in acute severe ulcerative colitis, you have to immediately start an IV hydrocortisone, 100 mg Citalopram or methylprednisolone, 60 mg per day. So after this day one, you start this. In day 3, you see the response after starting IV steroids. So how do you see the response? You see the Oxford criteria. So how do you, what is this Oxford criteria? You see the stool frequency and the CRP levels. So if the stool frequency is less than 3 per day, the patient has completely responded, and you can switch out the patient to oral steroids and add azathioprine. But if the patient is having an incomplete response or a non-responder, that means stool frequency is greater than 8 per day, or the patient is having a CRP of more than 45. In such case, they are all non-responders. In such case, they should need a medical rescue therapy or colectomy. What are the medical rescue therapies which can be given? You can give either a cyclosporin or you can give infliximab infusion, and then assess the response at day 4 to 7. Even after giving this medical rescue therapy in the form of cyclosporin and the infliximab, if the patient has an inadequate response, go for colectomy. So this is the roughly the management of acute severe ulcerative colitis. So based on True-Love-Witz criteria, you diagnose severe ulcerative colitis. So I told you before, what is severe ulcerative colitis? More than 6 bloody stools with fever, tachycardia, anemia, and high ESR. All these are acute severe ulcerative colitis. You start the patient of IV hydrocortisone, 100 mg on day 1. Day 3, you assess the response. How do you assess the response? You follow Oxford criteria based on whether the stool frequency has come down and whether CRP level has come down. If it has come down, patient has responded, switch over to oral steroids. Not come down, consider medical rescue therapy. You give either cyclosporin or infliximab. Assess the response in day 4 to 7. The patient doesn't show any improvement, go ahead with colectomy. So this is the flow chart for acute severe ulcerative colitis. Okay. This is surgical aspect. So in the surgical aspect, I want to cover this point. There are two things in ulcerative colitis. So in ulcerative colitis, the important point is surgery is curative. You remove the colon, the patient is cured of the disease. Whereas in Crohn's disease, surgery is not curative. Surgery is non-curative. So what you do in Crohn's disease, you do as minimal surgery as possible. So whenever you're doing surgery for Crohn's disease, you just try to concentrate on only the portion of the bowel which is affected. Whereas if you're operating on a patient with ulcerative colitis, the surgery of choice, the treatment of choice is total proctocolectomy, total proctocolectomy with ileal pouch channel anastomosis. Fine. So that is the surgery for ulcerative colitis, which is curative. Whereas in Crohn's disease, suppose if the patient is having a ileal stricture, You try to do, if it's a small segment, short segment stricture, you can do a stricturoplasty. If it is a long segment stricture or multiple strictures squatted over a small segment of the bowel, you have to do a bowel resection. So you confine only to whatever the pathology in Crohn's disease. Whereas in ulcerative colitis, it's a curative surgery. You completely do a surgical treatment of choice, which is restorative proctocolectomy with ileal pouch and anastomosis. Fine. So you completely remove the colon as well as the rectum. There are two things in this. One is, how do you do the pouch and anastomosis? Whether you do by Hanson technique or whether you do by staple technique. Why is it important? Because if you do an Hanson technique, if you do by Hanson technique, what you can do is you can do this anorectal mucosectomy, like I said in FAP. You can do this anorectal mucosectomy. You can remove by do a sharp dissection and remove this anorectal mucosum, and you can do an anastomosis of the ileal pouch in this dentate line. So this is the anastomosis, almost close to the anal verge. So this is the ideal technique which should be used if the patient with ulcerative colitis has dysplasia or cancer in the distal rectum. What is the disadvantage of this Hanson technique is when you do a mucosectomy, you disrupt this transition zone. Close to the dentate line, we have the anal transition zone that is rich in nerve fibers, and the incontinence rate is much more if you do anorectal mucosectomy. So as much as possible, if you preserve the transitional zone, the continence is better. Therefore, it is always better to go for a stapled technique like this in picture, in which the anastomosis between the ileal pouch and the anal canal is done by a circular stapler. Basically, what you do, you form a J pouch by stapling the two limbs of the terminal ileum, and then you use a circular stapler to form an anastomosis between this ileal pouch and the anal canal, forming a forming ileal pouch anal anastomosis. So in short, Hanson technique, anorectal mucosectomy is done, and the functional result is not better when compared to the staple technique. Whereas in staple technique, you preserve the anal transition zone where the nerve fibers are rich and the continence is better, and it is preferred surgery for young individuals. Fine. You understood this concept? So this is again the picture showing a double staple technique for ideal pouch anal anastomosis, and this picture shows the anorectal mucosectomy being done in A, and then after anorectal mucosectomy being done, we can see a suture, the Hanson ileal pouch anal anastomosis at the level of the dentate line, in which anorectal mucosectomy is done. But always the staple technique is better because it preserves the anal transition zone and the continence is better. Fine. These are the various pouch. This A, the pouch is constructed with only two limbs. So this is J pouch. Here the pouch is constructed with four limbs. This is called W pouch. Here the pouch is constructed with three limbs. 1, 2, 3. This is called S pouch. So what is the difference between all this pouch? Most commonly we constructed the this pouch, J pouch. It is constructed with the two limbs, which is 15 to 20 centimeter. Next, this is W pouch, which is three limbs, four limbs, around 12 centimeter size. And this is the S pouch. So what is this S pouch? It has a 10 centimeter limb, plus it also has this 2 centimeter efferent limb. So this 2 centimeter efferent limb is the characteristic feature of this S pouch, which is not found in any of this pouch. See, all this pouch, you don't see an efferent limb. Whereas in this pouch, you can see from this pouch till the anal canal, you can see an efferent limb. So in case if the pouch is not reaching deep the pelvis, or if your pouch length is shorter, the best pouch you can go ahead is the S pouch. So S pouch is, but the functioning of the S pouch is very poor because they need to self-catheterize to evacuate. These are the important points which you should remember as far as the pouches are concerned. There's a difference between all the pouch. The pouch which is more commonly constructed is the J pouch because it is simple, quick, popular, and the reoperation is also much easier with the J pouch. Okay. Which among the following? So another important thing is, which is this point is given in Substan also. Suppose when you are doing an ileal pouch, and the pouch after is not reaching deep inside the pelvis for you to anastomose, what are the maneuvers you can do so that you can make the pouch to reach the pelvis? So that is the another topic. So let's do the MCQ and then I'll tell you about the concept. Divide the remnant of the ileocholic artery close to its origin from the SMA. Is that a maneuver to increase the pouch length to reach the pelvis? Are you understanding what is the question is?
Yes, sir.
So true or false? Divide the remnant of the ileocholic artery close to its origin from the SMA. True or false?
False, sir.
True.
True. So ileocholic artery ligation is one of the initial step which you should do if your if your pouch is not reaching the pelvis for anastomosis. You understood that basically the pouch is short. The pouch is short, and you want to lengthen the pouch so that it comes deep inside the pelvis. So what are the maneuvers you can do? So one of the maneuvers is you ligate the ileocholic artery close to its origin. I'll show you the picture in the subsequent slide. The anterior and posterior peritoneum overlying the superior mesenteric vessels can be incised transversely at multiple levels. The exact
True.
picture is given in substance. So this is definitely true. This can be done. It gives an additional length of 1 to 2 centimeter. Fine. This additional length of 2 centimeter. Division of secondary arcade vessels can be done or not. It can also be done. No, it can be done. It is true. I'll show you what is the division of secondary arcade vessel. Last point, W pouch can be considered, which can reach the entire length. True or false?
False.
W pouch. No, W pouch, yes, definitely. So, which pouch can be used to, in case if the patient is having an
Yes,
insufficient
pouch.
length of the pouch? Yes, pouch, yeah. So the S pouch, though the S pouch function is inferior, but in case if you don't have the last option, which you can do is create an S pouch, fine. So let me explain all these maneuvers. So first maneuver which I said was to ligate the origin of the ileocholic artery. So this one, this picture shows this thing. So what they have done is they have ligated the ileocholic artery at the origin, and then this will give an additional length of around 3 centimeter. The other thing is division of secondary arcade vessel is basically they have preserved the ileocholic, artery, and sorry, this is not division arcade vessel. So basically, ileocholic artery is this one. So what they have done is they ligated the ileocholic artery at the origin. The other thing what you can do is you can divide the SMA distally. That also will give additional length. So either you can ligate the ileocholic or you can ligate the SMA distally. Okay. So there are two things. The other thing what you can do is you can multiple scoring of the small bowel mesentery both anteriorly and posteriorly. This will give 1 to 2 centimeter. So number one, ligation of ileocholic artery, ligation of the distal SMA, anterior and posterior scoring of the small bowel mesentery. So this is the ligation of the secondary arcade vessel. Basically, you ligate the ileocholic, right cholic artery, and you completely divide all those arteries. So basically, the blood supply is from the middle cholic, which is coming to the ileocholic and supplying the small bowel. You understood, no? So ileocholic is ligated, right cholic is ligated. Middle cholic through the marginal artery, it supplies the small bowel. Fine. So that's how it happens. So this is the division of the secondary arcade vessel. You divide everything. The middle colic through the marginal artery, it's supplying the small bowel. So this is another maneuver. So this is in a nutshell the flow chart. Normally, after you do the resection portal protocolectomy, when you construct the ileal pouch, the distance it should reach is 3 to 4 centimeter below the inferior border of the symphysis pubis. Okay, 3 to 4. If doesn't reach, what you can do is you can either ligate the ileocholic artery, which will give 3 centimeter additional length, ligate distal SMA, which will give 6 centimeter additional length, and the very important is preserve the right colon marginal artery and retrograde blood flow, which is this one. Preserve the marginal artery and retrograde blood flow from the middle colic artery. This will give additional 11 centimeter length. Okay, so these are the three things. And additionally, you can score the peritoneal lining of the mesentery, and you can finally consider S pouch instead of a J pouch. But the functional results are very bad when compared in a S pouch. Fine. So this is what in a surgical aspect of IBD is concerned. So the surgery is curative in ulcerative colitis, whereas in Crohn's colitis, whatever is the disease is involved in a segmental pattern, you try to address that alone and don't try to meddle with the remaining bowel. And whenever there is a problem with the pouch construction or the reach of the pouch in the pelvis, you have to do this mesenteric lengthening procedure by any of this technique. And I have given you a rough flow chart. And in short, the maneuver you can do is you can ligate the ileocholic artery at the origin. You can ligate the distal SMA. You can do multiple scoring of the peritoneum, and Subiston gives this multiple scoring of the peritoneum gives 1 to 2 centimeter additional length. And this is the part where you preserve the marginal artery and ligate all the ileocolic and right colic and allow the middle colic to supply the small bowel through the marginal artery. So this is what the picture is. Fine. And this is the flow chart of the thing. So you're clear with IBD? Any doubts on IBD? The last few slides I'm going to cover now. Fine, I'll go ahead. So I'll tell you nutshell about sigmoid volvulus. So identify the false statement regarding sigmoid volvulus. Polonic decompression is a highly effective one-time definitive treatment for sigmoid volvulus. So the answer is Mark. It is false. Can you tell me why it is false? I think you would have managed enough sigmoid volvulus.
Recurrent.
Yeah. Definitely. Polonic decompression is not a definitive treatment. It is just a bridging treatment for a patient who is presented to you with acute sigmoid volvulus. So what is so you have managed enough sigmoid volvulus? I'll just tell you briefly. Patient who doesn't have peritoneal signs, you can definitely go ahead and do a decompression either by a colonoscopic decompression or a sigmoidoscopic decompression, or you can do a flatus tube decompression in your emergency. But after that, that is not a definitive procedure. The patient will, once the colon is decompressed, it will again recur. So you stabilize the patient, correct the electrolyte, make the patient fit, and the definitive procedure for sigmoid volvulus is performing a sigmoid colectomy. That's all. The sigmoid colectomy is a treatment of choice. Fine, that is in a nutshell about sigmoid volvulus treatment. But if the patient has a sigmoid volvulus with peritoneal signs, directly go ahead with surgery. Don't think of doing a decompression. Okay. So option B, resection is a treatment of choice for sigmoid volvulus. True or false? Guys, resection is true. Wonderful. Even if detorsion of the sigmoid is successful, elective sigmoid resection is indicated because of the extremely high recurrence rate, which approaches 70%. True or false?
True.
Yeah. So only detorsion if you do 70% recurrence. So you have to do a sigmoidectomy in the same setting. Basically, the peritoneal signs in sigmoid volvulus needs emergent endoscopic detorsion. False. So this is again another false statement. So this is the two false statement in this thing. A patient with peritoneal signs needs emergency surgery, not emergency endoscopic detorsion. So another few points I want to add on colonic bleeding and ischemia. As I already told before, the rectum has a robust blood supply, but as far as the colon is concerned, there are watershed areas, especially in the left side of the colon. So the main watershed areas are one in the splenic fissure, which is the Griffiths point, and one in the rectosigmoid junction, which is the Studak's point. So this colonic ischemia can happen when there is a marginal circulation, collateral circulation is not adequate. Either the marginal artery of Drummond or the arc of Ryland is not doing its function appropriately. It can result in colonic ischemia, which can cause either a partial thickness ischemia or full thickness ischemia, resulting in a perforation. Fine. So identify the false statement regarding colonic bleeding. So let's see about bleeding. Diverticulosis is the most common cause of lower GI bleed, and majority need operative intervention. True or false?
False.
False. Why is it false?
Diverticulitis.
No, why it is false, because it is the majority doesn't need operative intervention. It settles without operative intervention. That is the reason. Okay. Vascular ectasia are most common cause of recurrent GI bleed in young individuals.
True.
True. They are common in older individuals, not in young individuals. So vascular ectasia is a condition which is present in older individuals, particularly in patients who have aortic stenosis and they have recurrent GI bleed, and these lesions are more distributed in the right side of the colon. Fine.
Yes, sir.
50 to 80% of all lower GI bleed occurs in the vascular orchid perfused by the superior mesenteric artery. True or false? True. Wonderful answer.
True.
Ulcerative colitis is much more likely than Crohn's disease to be manifested with GI bleeding. True or false? True. Okay. Ulcerative colitis has more chance of bleeding. Okay. So these are the two things which are false, A and B. Fine. And yeah, the vascular ectasia I already told before. The predominant cause of recurrent lower GI elderly patient, their lesions are 5 mm. Right side of the colon is a typical site of vascular ectasia. And when bleeds, it presents with massive hemorrhage. No, it doesn't present with massive hemorrhage. That is a false statement there. Okay. And mostly it has recurrent self-limited episodes of bleeding. So this is a typical picture of vascular ectasis of colon. You can see a central feeding artery from which a lot of spider wings like thing emerge, like telangiectatic wings. And this is the thing which is given in Sabiston. Always remember the technetium, the nuclear scan, that is the RBC scan, can detect active bleeding even at rates below 0.1 ml per minute. But scintigraphy cannot exactly localize the bleed. It can detect the bleed rate at below 0.1 ml, but it cannot exactly point out where it is bleeding from. Whereas CT angiography can detect blood loss at the rate of 0.5 ml per minute. At the same time, it can tell from where it is bleeding, with which you can do an embolization. Fine. So this rates. So again, as I told, colonic ischemia, like any other part, colon also like small bowel is susceptible to ischemia. So now identify the false statement regarding colonic ischemia. More frequently involves the right half of the colon. True or false? True. I told no, it more frequently involves the left side of the colon. Fine. Okay. So left side is a part which is more common. It's not true. Segmental colonic involvement is most common pattern found in colonic ischemia. See, colon has a robust collateral circulation. So it's most commonly the involvement is not like a small bowel. Like if SMA is involved, the entire thing will be gangrenous. But in colon, it doesn't happen. Usually a segmental pattern. And most commonly, the patient might not even have observed that ischemic pattern, the acute episode of ischemia. He might have had some pain with some diarrhea, with bloody diarrhea, which will have resolved on its own. And after some days, the patient will present to you with a colonic stricture, which you retrospectively you should suspect it might be because of a colonic ischemia. Fine. So segmental colonic involvement is the common pattern for colonic ischemia. That is true. CT scan combined with a colonoscopy is needed for diagnosis of colonic ischemia. True or false?
False.
No, it is true. So early colonoscopy should be done carefully, and in the colonoscopy you can see areas of hemorrhagic necrosis dispersed interspersed between the normal mucosa, and CT scan will show colonic wall thickening with pericolonic patch standing. The most characteristic finding on barium minima is thumb printing or pseudotumors. True or false?
True.
True. Fine. So the first option is false. Again, identify the false statement in ischemic colitis. The most common form of GI ischemia is ischemic colitis. True or false? True. Wonderful. The fixed point and pseudox point are susceptible to ischemia during episodes of low blood flow. True or false?
True.
True. Wonderful. The majority of patients with ischemic colitis do not require urgent surgical intervention. True or false? Most of the time, this ischemic colitis will settle on its own, and it may not need a surgical intervention, unlike a small bowel disease. Fine. So mostly it will settle on its own. It doesn't need surgical intervention in all the patients. Rectum is more susceptible to ischemic injury and the second most common site after right colon. True or false? Obviously, the option is completely false because rectum is supplied by three major arteries, one from IMA, one from internal iliac, and one from internal pudendal artery. So it has a robust blood supply, and it definitely doesn't not susceptible to ischemic injury. So that's a false statement. Fine. So the next few points on diverticulosis. Let's do this MCQ. Identify the true statement regarding diverticulosis. In Asian population, diverticula are more common on the right side of the colon and generally represent true diverticula. True or false?
False.
So diverticulosis, no, it is true. Diverticulosis, there is a condition called endemic diverticulosis, which is common in the Asian population. Only in the Western population, we will see the actual diverticulosis, which is commonly seen in the sigmoid colon, which is because of the dietary habits. Whereas in Asian population, this is a type of endemic diverticulosis, which is common on the right side, and it is all true diverticula. Okay, this is a point which is given in Shackelford. Kinchy 3 refers to generalized purulent peritonitis. True or false?
False.
Kinchy 3 refers to generalized purulent peritonitis.
True.
True, that is a true. Okay. Polovesical fistulas are the most common type of diverticular fistula. True or false?
Yeah, my
So when
answer.
when there is diverticulitis, the inflamed diverticulum gets adhered to the surrounding organs, and the most common organ which gets adhered to is the bladder. Most commonly, dome of the urinary bladder. Okay. So the urinary bladder, which part of the urinary bladder? The dome of the urinary bladder. So how do you detect it? The patient will have recurrent urinary tract infection, Sometimes you can see air in the urinary bladder. Okay. So how do you diagnose it? You can do a barium enema. Barium enema will show the colovesical fistula in 50% of cases. And you can do a cystoscopy. You can see at the site of the fistula, you can see a bulla. Okay. So this is the colovesical fistula is the most common type of diverticular fistula. That is also true. Diverticula are the most commonly seen in the plane between two antimesenteric tinea at the point, at the point where the vessel enters the bowel wall. True or false? At the point where the vessel enters the bowel wall. True. Okay, it is always present in the between the two mesenteric tinea. Fine. Laparoscopic lavage has emerged as an attractive alternative therapeutic approach for patients with Hinchey stage 4 classification. True or false?
False.
False. Yeah. Somebody has to mute the mic. Dr. Piyush has to mute the mic. Fine, I'll go ahead. So Hinchey 3, you can do a laparoscopic lavage. When there is Hinchey 4 is basically a fecal peritonitis. Obviously, you can't do a laparoscopic lavage for a fecal peritonitis. In that case, you definitely have to do something for the bowel. So you can't do a laparoscopic lavage for them. So these are all the right statement in this patient. Okay. So management of diverticulitis for uncomplicated, give antibiotics, and even in uncomplicated diverticulitis, you assess whether the patient has high chance of recurrence, and then if there is high chance of recurrence, you go ahead and do a diverticulectomy. For a complicated diverticulitis, for Hinchey stage 1 and stage 2, stage 1 is basically a pericolic abscess, stage 2 is basically a walled off abscess, stage 3 is basically a purulent peritonitis, and stage 4 is a fecal peritonitis. So in stage 1 and stage 2, you can give antibiotics and a percutaneous drainage. Whereas stage 3 and stage 4, because it is a feculent and a purulent peritonitis, you will do emergency surgery. And in particularly, the recent advances in Hinchey stage 3, you can just do a laparoscopic lavage without doing anything for the bowel and see if the patient improves. If the patient doesn't improve, you can go ahead for do a emergency colectomy. Otherwise, you can just manage with laparoscopic lavage and drain all the pus and give a lavage in Hinchey stage 3 and not in stage 4. So this is the Hinchey classification. There is one modified Hinchey. It's given in Shackelford. Subsystem gives only Hinchey classification. Okay. So the last aspect on large bowel obstruction, I am not going to cover the actual mechanical obstruction, which you have very commonly seen colorectal cancer, and you know what to do for colorectal cancer obstruction. I want to tell some points on the colonic pseudo obstruction, also called as Ogilvie syndrome, in which basically there is a picture like a colonic obstruction, but there is no mechanical obstruction. Basically, it's a functional obstruction. So what you should do for this patient? So let's do this MCQ. Identify the true statement regarding colonic pseudo obstruction. Pseudo obstruction is also called as Ogilvie syndrome. Is a misnomer as mechanical obstruction is present at the splenic fracture. True or false?
False.
False. So the mechanical obstruction is not present at the splenic fracture. Though in radiology, you can see a cutoff present at the level of splenic fracture. There is no mechanical obstruction in Ogilvie syndrome. Fine. One mechanism thought to play a role in pathogenesis is parasympathetic overactivity overriding the sympathetic system.
True.
False. Parasympathetic overactivity is less in a case of pseudo obstruction. See, parasympathetic overactivity means the patient will be having a very hyperactive bowel. So the statement is false. Water soluble contrast enema is a preferred initial test in suspected colonic pseudo obstruction. True or false? True. Wonderful. So the suspected initial test in a large bowel obstruction is not colonoscopy. The initial test to confirm is water soluble contrast enema. I mean, we actually don't follow this protocol, but this is what the scenario given. We actually go by the imaging findings, but this is what the thing which is given in Subsystem. So as far as for your exam purpose, you should go ahead what is given in the book. So water soluble contrast enema is the preferred initial test in suspected colonic pseudo obstruction. Recurrence rate after single administration of neoestrogen is more when compared to endoscopic decompression. True or false? False. Yes, very good. The single administration of neoestrogen works wonders. Within 10 minutes, the patient will have the moment of the colonic decompression, and only if but neoestrogen should be given very carefully under in ICU setting. You should make sure you have atropine in your hand and anesthetists to manage any complication which happens because of the administration of neoestrogen. Fine. So this is a flow chart which is given in colonic pseudo obstruction. So basically, remember this point: when there is peritonitis, definitely you have to go for laparotomy. Otherwise, the ideal first step is a enema, water soluble contrast enema. So in the contrast enema, if there is no obstruction, if there's obstruction, it doesn't come under pseudo obstruction. Doesn't come under ogilvy. If there is no obstruction, it is Ogilvy syndrome. How do you manage this? You do all this decompression by nasogastric tube, correct fluid and electrolyte, discontinue narcotic. See the cecal diameter, because I said before, cecal diameter more than 12 centimeter, you definitely have to do a surgical decompression because the high chance of cecal necrosis and cecal perforation. So cecum less than 12 centimeter. So then you can carefully go ahead and give first neostigimin. Neostigimin is basically increases the acetylcholine concentration. It's a parasympathetic mimetic. Or you can give, yeah, very good. Catchpole regimen. That's what is given in Bailey and Dow. Catchpole regimen, neostigimin, or you can give epidural anesthetic. Basically, epidural anesthesia, it cuts out down the sympathetic activity and increases the parasympathetic activity. So neostigimin is the first choice, followed by epidural anesthetic. If there is no resolution with these two, neostigimin and epidural anesthesia, you can try very carefully colonoscopy decompression. Even with that, if there is no resolution, you can do a laparotomy. So remember, for colonic pseudo obstruction, it's a functional obstruction. No mechanical obstruction is present. Even though it's a pseudo obstruction, in imaging there might be a cutoff seen in the splenic fissure area, and at the same time, the pseudo obstruction might it's a condition in which bowel sounds may be present. And when you're the ideal investigation as given in textbook is water soluble contrast enema, and if the contrast enema doesn't show any obstruction, you can start your treatment for pseudo obstruction in the form of giving neostigimin, and neostigimin works wonders. A single administration is enough for the management of a colonoscopic for decompression of the colon, and if not relieved by neostigimin, epidural anesthesia is another option, and finally colonoscopic decompression. And if not resolved by all this, go for laparotomy. So this is in nutshell with colonic pseudo obstruction. Fine. Okay, guys. Thank you. That's all I have for today. And if you have gonethadine given ADR block, I don't know, Dr. JGB, I'm not sure about it. Can you tell me about that? I've never, I mean, we basically have not, only once, I think, in an ICU setup, we have used this neostigimin. Otherwise, I have not used, I have not managed Ogilvy and all very commonly. It's not very commonly I've seen. I managed only once with neostigimin back in JIPMA. So I'm not sure about it. What is gonethadine? How do you do?
20 mg gonethadine is given in 100 ml NS over 40 minutes. So that adrenal block. So you do the sympathetic block first, and then give the parasympathetic neostigimin over 1 minute, 2.5
have you used
mg.
it? Have you used
No,
it
not
clinically?
used it, but I've read about it. So
you read about it. Oh, gonethadine action. Okay, fine. Okay, that's wonderful. Okay, I'll read about it. Okay,
yes.
someone has asked some question. Can please repeat about D3 lymph node margin? So basically, I'll share you a paper. That's a wonderful paper because the pictures will explain everything there. I'll again explain here. Plus, I'll share you the D3 lymphadenectomy paper. Just 1 minute. So basically, D3 lymphadenectomy is a concept given by the Japanese. Where is this? I'll go and come. It's an operating from my iPad. Yeah. See, this is the D3 dissection. See, till now we have done, sorry. Till now, what we have do is central vascular ligation only. For all hemicolectomies, you ligate the all the vessels at the origin. But this is a recent concept which is introduced by the Japanese, and I think there is one trial also for this. I'm not sure. I forgot about the trial. So where D3 lymphadenectomy they have compared. So what is this? Basically, normally when you're doing right hemicolectomy, you finish your dissection here. Just a minute, I'll just see. So normally you ligate the vessel close to the origin of SMA, like ileocholic artery, you ligate here, and ileocholic vein, everything you ligate here, and you finish off the surgery. But what they say is D3, you might have lymph nodes even close to the lateral border of the SMA. So what you should do, you should clear this rectangular side, which is from the inferior border of the pancreas, along the left lateral border of the SMA, and over the anterior to the SMV as well as SMV. So what is this exact boundary is 5 millimeter proximal to middle colic artery, 5 millimeter distal to ileocolic artery. The left lateral border of the SMA you must see after the dissection, and 1 centimeter lateral to the SMA and SMV. So this is the borders of this D3 dissection. Okay, I'll share you that Japanese paper. It's a wonderful paper. With that picture, you'll be better able to understand. Fine. And second most common site for METs in sigmoid colon cancer, lymph node, liver, lung, and brain. The first is obviously lymph node, and I think for sigmoid colon, the second most common will be liver only. I'll confirm it again. This question by Dr. Aishwarya has asked. I'll confirm and share it in the group. Only the lower rectal cancer, the most common site will go to the lung. The closer, because it is drained both by the systemic circulation and the portal circulation. The lower rectum goes to the lungs commonly. So obviously it will be the lymph node is the most common. And the second most site I think should be liver only. I'll again check with if there is any data given in the book or literature. So this I will confirm Dr. Aishwarya's question. And thanks, Dr. JJB, for the goenathodine point. I didn't know that. So, and one more thing, I'll share the D3 lymphadenectomy asked by Dr. Lomesh. And one more thing which I said I'll answer is carcinoma more likely in ulcerative colitis or CD. I don't know the exact literature, the frequency of this. That I will refer. So 3 things I'll refer: D3 lymphadenectomy, exact incidence of carcinoma in ulcerative colitis and Crohn's disease, and most common sites for medicine